Helen, thank you, Helen. That was thanks a lot for setting this up and being the workhorse you and Rob behind to get this off the ground. So basically, the intention is that because this network's being set up between Southeast and Southwest, the important, I don't know whether many of you know this. So our intention is that there will be the way the services are going to run is the Southeast will be Kumtaf, Moganak, Cardiff and Vale, and AB working together, and the West Wales cohort would be SP and Havildar. Powis filters into both. So that's what is being set up. Hopefully it'll be a full-fledged network, which will be something that we could actually, like, so there'll be a lot of commissioning, there'll be all those sort of things become a little bit more streamlined. So there are pathways being set. There are a lot of things that are happening, which is good because so far quite a lot of things have been all ad hoc, and this service is being run sometimes on goodwill, sometimes on necessity, sometimes on urgency, but hopefully there will be some structure to it. So what we thought was it'll be a good opportunity to start talking, start discussing things, and trying to harmonize things, make sure that the service provision, yeah, there may be certain services like Kumtaf who do not have a spinal service, but we are the spinal service for them from Cardiff and Vale point of view, just trying to make sure that patients get equitable care across the region, in the Southeast region. And I'm sure there are good practices in Kumtaf, there are good practices in AB, there are good practices in Cardiff and Vale. It's not just Cardiff and Vale. Sorry, I represent Cardiff and Vale, but that is not the thing. The intention is that it is going to be something that could be set up across the board and which we can learn from and pick things up. And that is the reason that we set this up. So this is the first one of the ones that we're going to run where, so we started with something quite simple, talking about radicular pain. And then of course, we'll talk about axial back pain, talk about other things and a lot of different issues that we will have to cover as we go along. So I don't want to waste too much time. So fortunately, we got input from all three, and we would like to have like, we got representation from Kumtaf, we got representation from Cardiff and Vale on this panel. So I'll quickly introduce around. You heard from Helen. So on top of my screen, first one is Gavin Clay. Gavin is a musculoskeletal radiologist based in Kumtaf who does a lot of intervention stuff for spinal patients, for injections and etc. So, and he's quite well involved higher up in the Royal College of Radiologists as well from an interventional background. Next on my list is Naz Moeddin. Naz is one of my spinal surgical colleagues who is quite experienced, who's done a lot of work in setting up a few things for us in the pathways here. And he's done his fellowships here with us and in Manchester. So Naz, thank you for joining us. Next on the screen for me is Rob Goldsmith. I think most of you know Rob. I don't need to introduce him. He's been around a long time as an ESP. He's done a lot of work on the back pain pathway. He set up quite a few different things for us locally with the radiculopathy pathway. So it's good to have Rob's experience and expertise, so which he'll share with us. So thanks, Rob, for joining us. And another thanks to Rob is he's been pivotal in trying to set this up along with Joe, Helen, myself, right? Next is Joe. I think most of you know Joe. Like, Joe was a ESP virtually when I was a fellow. So Joe's been around a very long time. She's done a lot for our service, and Joe's been one of the common themes who's been around for a very long time, set up pathways for us, set up a lot of different things. And I'm sure you've all come across Joe in your interactions in the region somewhere or the other. So thank you very much, Joe, for joining us. And last but not the least, we've got Mr. Manoj Thomas, who's a consultant spinal surgeon based in AB. He's been around for quite some time in AB. He's the clinical lead for AB. He's represented AB, Anna and Bevan in the network meetings, lending a voice for the patients from the Gwent region. And it's good to have Manoj Thomas here as well. Manoj, thank you very much. So without wasting much further time, so Helen, do you have the program in front, or is that something that's we've distributed to everybody anyway?
The program for this afternoon is we're going to book into 3 sessions. So the first session is concentrating on management of spinal conditions, looking at assessment in primary care through to secondary care management, and looking onward to radiological involvement. The second session is looking at management of radicular pain, stroke sciatica, again from a primary care physiotherapy perspective into secondary care management. And then the third session is a panel discussion looking at an interactive session with all panel participants to answer your questions that we put in the question and answer session. Can I ask, I have put it in the chat function as well, can all the delegates please mute their mics, please, so that the recording is nice and clear for our panelists both to present their lectures and to talk themselves. So we're going to start off with Joe Hutchings talking about spinal management and assessment in primary care. If I can hand over to you, Joe.
Right, good afternoon everybody. I hope you can hear me loud and clear. I'll just share my screen. So let's see, slideshow. So I'm talking to you today from the point of view of a clinician. As Hashin said, I've got a lot of experience assessing patients with spinal pain from many years ago, working in secondary care spinal services, setting up ESP clinics, and more recently I'm working in primary care as a first contact practitioner. So a lot of this is my experience, hopefully coming through with reference to the evidence. I haven't produced a reference list, but if anybody wants any more information, then please let me know after. So initially, I just wanted to mention a little bit about the Carden-Vale spinal pain pathway, and I'm sure there are versions of this available in CUMTAV and AEB, but this is just to set the scene for what I'm talking about this afternoon, and also how our assessments fit into, you know, this structure. So the talk I'm talking about this afternoon is about the initial GP treatment and assessment. So in primary care, which is the box here on the far right, so which includes after exclusion of red flags and radicular symptoms, advice and education, appropriate review and onward management if needed, or self-management advice to the patient. So yeah, this is the guiding document really that we will work towards, you know, when we're initially seeing a patient in primary care. So working as a first contact practitioner, well, this service has been developed nationally to, sorry, I can snip through. So up to 25% of consultations in primary care are about musculoskeletal problems. And so in order to help out primary care, physios have been being used now to help manage and assess and diagnose these problems. So the role of an FCP can involve standard physiotherapy assessment and treatment, but also assessment guidance and triage in onward management, and also independent prescribing and injection. And generally speaking, these are much shorter appointments compared to a traditional outpatient physio appointment. So there's a lot to cover, just like there's a lot to cover this afternoon. One of the guiding principles is putting the person at the centre of their care. And meeting the needs and expectations. So the initial part of our assessment really obviously is about the problem and its impact on the patient, and meeting the needs and, you know, what the patient really wants from this this consultation. It's been identified that a lot of patients, that their key concerns are its impact of the problem and it has on their daily life. What are the best management options? Any practical questions around that, and also the future and their future management. One model in primary care that's been recognised as something that can be helpful is to understand the patient's ideas, concerns and expectations. And as part of a consultation at some point, I, always trying to find out from the patient, what is their understanding of the cause of their symptoms? What are their main concerns and what are they expecting from this outcome? What do they want help with? And so setting the agenda and identifying the agenda for the patient is a really important part of us working in FCP. It can significantly influence the outcome of the consultation. There's a lot of evidence to demonstrate prescribing is less, onward referral is less, and it does facilitate involving the patient in their decision making and the process of shared decision making. So, I mean, historically, our clinical assessments were always carried out in person. Over the last 18 months, things have changed somewhat. And now initially we are assessing a lot of patients virtually, which in a triage setting isn't always a disadvantage. 80% of our diagnosis is based on the subjective history. So speaking to a patient over the phone can give us a lot of really helpful information. And obviously, if there are concerns, we are able to arrange for patients to come in for a face-to-face assessment. That might be for neurological screening if they're giving us some problems that we think there's weakness, that's deteriorating. If you want to assess bony tenderness, if you want to see the true impact of the symptoms and level of function and disability. So, you know, I would always encourage people, if they have got any concerns, I'm hopeful that, you know, at the health boards, the opportunity to meet people face to face for assessment now is becoming much freer. And, you know, with the COVID risk declining, you know, we are able to arrange for any patient to come in for a face to face assessment. In our questioning, we try and be open, asking the why, how, can you, what, asking nice open questions, and asking the patients to tell you exactly what their initial concerns are, what they want from the consultation today, and then also involving reflection back to the patient of what they've said, to make sure that they know you've heard them. So identifying the patient's agenda is one part of our consultation, but obviously the initial part of the spinal pain triage, so screening for red flags, identifying things that need emergency or urgent investigation, or things that, you know, we can watch and wait. But that's in the first instance is a really important part of our assessment. So, and I'll go through some of those symptoms in a little while. So I suppose that would be the joint agenda of these assessments, meeting what the patient needs, but also making sure we're doing our job thoroughly and well. So presenting symptoms that I'd be wanting to find out about would be pain, neurological symptoms of pins and needles, numbness, weakness. When you're talking of caudal equina, we want to find out about bladder or bowel or sexual disturbance problems, what the distribution is, whether you're talking of axial symptoms or peripheral symptoms, leg or arm pain, and which is worst. You know, is it the arm symptoms or the leg symptoms, or is it more axial pain? Timescale of onset, so how long have they had the symptoms? Is this something that it's only a few days old, or has it been a persistent problem that they've had for many years? Has there been any trauma? And how are symptoms changing? Are they getting better, getting worse, or staying the same? And all the answers to these questions will guide your management in terms of further investigation or watchful waiting or more support in other services. General health, you know, also something that we want to be really clear about. How are they feeling medically? Are they feeling systemically well? Are their other health concerns stable? And symptomatically, how they are affected in terms of function, and also how they feel, you know. So we want to find about whether they're in work, hobbies, sleep, whether their mood is affected, and all these things will have a role to play in terms of what you decide to do next. So with regards to the red flag assessment, there was a really good paper that was produced last year by Laura Finucane, which was used to develop a framework for the assessment of red flags in spinal pain. So they looked at all the red flags that are available and their use in identifying serious pathology. So When review of the literature, there were 119 symptoms and 44 signs, so there's an awful lot of red flags available. They concluded that the identification of an individual red flag is not informative, and really we need to look at combinations in terms of clinical presentation and the symptoms that patients are complaining of. The best tools that are available are with a thorough subjective history and an objective examination to decide whether or not you feel those red flags, are something that need further investigation. Looking at things, and particularly with an individual patient profile of their age, sex, past medical history, and that's going to give you some idea of an index of suspicion. Is this something that you need to be concerned about? Is this something that needs to be acted on now, or is this something that we could watch and wait? And so essentially there was a panel of experts, and they've produced a framework for cauda-equina, spinal fracture, spinal metastases, and infection. So if I go through these slightly in more detail. So basically, cauda-equina syndrome is the one syndrome that we all want to identify as soon as possible because of the complexity and also the severity, of the ongoing problems that if you don't get acted on urgently. It's obviously a very rare condition, 0.02% instance in UK primary care, so very rare. However, it is a very time sensitive condition, and essentially if you're querying it may be presenting, it's something that needs to be acted on today, with a view to avoiding the life-changing outcomes. Potentially could end up with these symptoms not being managed in a timely fashion. So the relevant symptoms that we would say as a precursor are the unilateral or bilateral radicular pain with dermatomal distribution and myotomal weakness. And we need to be asking very carefully about the symptoms possibly linked to cauda-equina syndrome. I'm sure, so in the framework, these are the symptoms that Finucane et al. Identified with a high degree of clinical suspicion. So sensory change in the lower limbs, motor disturbance, sensory change in the saddle distribution, change in the ability to achieve erection or ejaculation, loss of sensation in genitals, change in urinary frequency, urinary function. So for example, frequency retention, incontinence, bowel incontinence or constipation, and then, as I mentioned, unilateral, bilateral leg pain, which may be a progression from just low back pain, and it can be alternating in limbs with progressive lower limb neurology. So those are the red flag symptoms that the Finucane identified as being highly suspicious of cauda-equina syndrome. I'm sure you've all seen the warning cards. These are now available in 29 different languages, and if you have concerns that this may be something that's a developing situation, then informing the patient very clearly of these symptoms. These cards are really helpful. I know in Cardiff, I believe in radiology, Pathology is also distributing them to patients who are being scanned if they've been identified with a large central disc, even if they have no cauda-equina symptoms. So this is something that we take very seriously, and I'm guessing that there will be pathways available in all the different health boards in Cardiff. If we have any of these concerns, the patient is sent to EU. In Cardiff and Vale, we're lucky we've got the CAV 24/7 phone line, so we would call the phone line with a view to arranging the patient to attend EU for further assessment. But these are symptoms that need to be acted on today. Okay. So then moving on to spinal fractures in the framework. It's been identified as the most common serious spinal pathology. Sudden onset of pain at the thoracolumbar junction possible, possibly after relatively low impact trauma, but it can be after significant trauma. The degree of pain varies from being really low to very severe. On examination, you may see slight increased bony prominence due to an increase in thoracic kyphosis because of the wedging. Tendon to percussion, if it's something of concern, the plain film would be your investigation of choice. And obviously, it's secondary to the spinal fracture, it can be down to spinal mets or multiple myeloma with some spinal pathology. So the risk factors, previous osteoporotic fractures or concurrent risk factors for osteoporosis, for example, steroid use, past history of cancer, particularly breast, prostate, lung, kidney and thyroid, severe trauma causing immediate spinal pain, focal bony tenderness in the midline, postmenopausal women and of older age. And a history of falls as well related to other comorbidities can also be a risk factor. The symptoms that potentially would be of concern are thoracic pain with a past history of cancer or osteoporosis, severe unfamiliar pain that is worsening, neurological symptoms of gait disturbance, problems with coordination, bladder or bowel disturbance, spinal tenderness, any change in spinal shape. And one point that they make in the Finucane paper is abrasion on the skin following trauma with central spinal tenderness. So malignancy I've touched on previously, bony metastases from the 5 primaries possible. It's the second most common serious spinal pathology. Obviously, because medical treatments are improving, people are living longer, so that's increasing the risk of metastatic bony disease, increasing age. And this again is something you need to pick up. We want to pick up early because late diagnosis then is, increases the risk of spinal cord involvement and neurological problems. So the symptoms that we might suspect: progressive pain, possibly band-like, unable to lie flat, night pain, possibly generally feeling unwell due to hypercalcemia, non-mechanical spinal pain on tendon percussion, neurological disturbance, unexplained weight loss, reduced sensation, and then spinal tenderness on percussion. So there's quite a lot of overlap between the fracture and malignancy. The other condition I felt would be helpful to mention from a primary care point of view is spondyloarthropathy. It's recognised that there's often a significant delay to diagnosis in Europe. It's on average 11 years from initial onset of symptoms to diagnosis. If you have concerns, the HLA-B27 and MRI of pelvis or spinal imaging with SI joints inclusion is important. I don't know if anybody's seen this, but this is a very nice infographic that the BMJ have produced, which talks you through axial spondyloarthropathy and clinically. So these are the symptoms that we would be concerned about. So back pain before the age of 45, lasting longer than 3 months. Waking during the second half of the night because of symptoms, first degree relative, current or path enthesitis, which is inflammatory change where the tendon attaches onto bone, current or past arthritis or psoriasis, significant improvement taken within 40 hours of starting NSAIDs, and that they improve with movement, and buttock pain. And essentially, if there are 2 or fewer of those conditions, the idea is to reassess at some points. It's unlikely to be a spondyloarthropathy. 3 or more positive, then they suggest getting HLA-B27 performed, and 4 or more of those factors, they would suggest referral onto rheumatology, performing the blood test, because it is likely to be a spondyloarthropathy. So with regard to infection, these are some of the symptoms that you might suspect the patient is presenting with: feeling unwell, recent UTI, past history of TB, diabetes, intravenous drug use, HIV, and then with severe pain and systemically unwell, and possibly with urgent neurology. And obviously that's something that needs to be looked at immediately. So the other MSK causes of back pain that can contribute are the hip, obviously, and the SI joints, past history, distribution of symptoms, pattern of symptom change with activity can give you guiding factors. Clinical assessment, you know, looking at hip range of movement, doing pain provocation tests for the SI joints. And I suppose bottom line is that imaging of those areas may be helpful also to confirm your diagnosis. So other medical causes of back pain are aneurysm, pelvic causes, abdominal causes, and these patients will present and they will be unfamiliar to physio. They won't be a mechanical pattern. They won't be the history that we generally feel. Obviously, these patients are going to be much fewer in number. If the symptoms don't add up, if there is strange distribution, the patient has other systemic symptoms, GI symptoms, GU symptoms, then you know, these are other symptoms, other conditions that it may be helpful to consider. And working in FCP, we would ask the GP to perform bloods or arrange further review, medical review with the GP. Just thought I'd include a little bit in the start back questionnaire. I do try and include it in patients I'm assessing with back pain. It's obviously a prognostic questionnaire to identify patients who are more at risk at developing persistent back pain, and I found it helpful. It does open the window to discuss other issues, like what are you really concerned about? You know, the yes/no answers. What patients respond yes, worrying thoughts. Well, what are you worried about? So it does allow you to discuss these psychosocial factors, which again are a really important part of assessing patients in primary care. So coming back to the decision tool then for the early identification of serious pathology, you know, determine your level of concern based on what the presenting symptoms are and the person's profile, deciding on a clinical action based on your level of concern, and if things need to be stepped up urgently, you know, how you do that locally. We have pathways in Cardiff, they will be available everywhere. So if there are no concerning features, beginning a trial of therapy, with advice, reassurance, referral into outpatient physio. A few concerning features, you might want to monitor the progress closely and make sure things are going in the right direction. If there are some concerning features, yeah, these are patients where you may want to arrange further investigations. And obviously, if there is some very concerning features, emergency referral back to the GP or to EU. So most patients do want to know, what is the cause of your symptoms? Non-specific or mechanical low back pain is a diagnosis of exclusion. So once you've excluded many other serious pathologies, that is likely to be what you're discussing with patients, reassuring them that it's unlikely to be down to any serious structural defects. Discussion of prognosis. For most people, it's good at 6 weeks. But the evidence is by 12 months, pain levels are low, but we do know that it can be very recurrent. And so discussing options for further management can be helpful. Yeah, so what are the options that they have to, you know, to manage the condition? Well, further investigations are unlikely to be helpful for purely axial back pain. Clinical assessment can be really helpful if you're not with a person face to face. The self-management strategies of pain management to allow function, remaining active, a graded return to full function, lifestyle factors, smoking, stress, sleep, those things are all really relevant for a lot of people with back pain. If somebody needs further support, the symptoms have been more persistent, possibly your outpatient physio referral. And if they're very persistent and struggling physically, then we, you know, a combined physical and psychological program. In Cardiff, we have Back in Action, which can be really helpful as well. And if, you know, if appropriate, it may be helpful to refer them in for an interface assessment in a CMAT setting to discuss what further management options are. Rob's obviously going to go through this in a lot more detail later, but the radicular symptoms, which we would describe as dermatomal, worse in the limb, aggravated with coughing or seizing with positive neural tension tests. Objective neuro can be helpful to exclude significant neural compromise. The symptoms are likely to be linked to sensitization or irritation of the nerve root. Generally speaking, the prognosis is good between 6 and 12 weeks. Yeah. Some patients do have more persistent symptoms, and for those that aren't settling, we have the radicular pain pathway, which Rob will speak about. You will still want to give them the same advice on activity and activity modification. It may be helpful to consider a neuropathic agent. And yeah, as I said, if things aren't settling, it may be helpful for the further investigation and management. So in summary, it's important to consider the patient's agenda as well as yours when you're assessing patients in primary care. It's obviously important to exclude any red flags or any symptoms that may indicate a non-mechanical problem. The timescale and natural history will guide you in terms of whether things need to be investigated further. And one reflection of working in FCP is that actually empowering the patient with regards to timescales and future prognosis is really important. If you're giving them key timescales for improvement and symptoms aren't improving anticipated, it makes sure that they've got the ways to get back in touch with you for further assessment, or if the symptoms are worsening. So ensuring the patient is in control to arrange further review is really important as well. Right, so obviously if you've got any questions, put them in the Q&A box. That's it for me now, so diolch.
Thank you very much, Jo. And as Jo said, if anybody's got any questions for the later session, if they can please use the Q&A and we'll touch on them in the panel discussion. If I now move on to Mr. Modine, who's going to talk about red flag management from a secondary and, in CUMTAF's point of view, tertiary management from Cardiff and Vale. Thank you.
Good afternoon, everyone. Naz Modine. I'm the consultant spinal surgeon working in Cardiff. I hope you can see my screen. So I'm going to be talking about red flags. So red flags are prognostic variables for serious pathology, such as benign or malignant tumor, infection, fracture, or quad-equina syndrome. Only 1% of cases of low back pain are caused by serious spinal pathology. Unfortunately, with a few exceptions, the prognostic strength of individual red flags or a combination of red flags is not known. There's been a little bit of guidance on their use, and they've been left to individual interpretation. For spinal pathology, there are about 163 red flags, of which 119 are based on symptoms and 44 based on the patient's physical examination. The high number of red flags presents a challenge in terms of their everyday practical utility. So what I'm going to do is I'm going to present some cases which would suggest they are serious spinal pathology and which could be encountered in our clinical practice. So case one is a 38-year-old female. She had a long-standing history of low back pain and unilateral leg pain. She also has some history of some stress incontinence. She presents with a weak history of bilateral leg pain. So there's a change in the way that her symptoms have progressed. There's also a change in her frequency of micturition. She denies any bowel symptoms. On examination, she was tender in her lower lumbar spine. Her power was 4/5 in both lower limbs, and the sensation also reduced bilaterally in L5 and S1 dermatome. Rectal examination revealed that there was decreased sensation to pinprick around the perianal region. However, the anal tone was normal. So she's got quite a bit of red flag signs and symptoms suggestive of quad-equina syndrome. So she was referred as for an emergency MRI scan. So she went to the hospital. She had an MRI scan, which revealed a large disc prolapse at L4-5, causing significant compression of the quad-equina. And she had to have an emergency decompression surgery. Now the second case. It's a 69-year-old male with a history of bowel cancer. For the last few days, he's been complaining of increasing thoracic back pain. He's present even at night. He says that he's feeling unsteady when he's walking. He intermittently gets some pins and needles in both lower limbs. Denies any bowel or bladder dysfunction. When he was examined, He was walking with crutches. Previously, he was quite active. He could drive his own car and he was still working. He's got weakness in his legs. He's got bilateral numbness. And also reflexes were quite brisk, and he had positive clonus, all suggestive of upper motor neuron signs, suggesting there may be some problem at the cord level. So he went on to have an urgent MRI scan, and that revealed that there was a lesion in his thoracic spine causing cord compression at the level of T3. There was also another lesion at T5. And because of his progressive symptoms and neurology, he had an emergency surgery in the form of a posterior decompression and stabilization of his thoracic spine. This is another case of a 44-year-old male who had long-standing history of low back pain, which has been managed conservatively. He had seen a chiropractor recently who had performed an acupuncture to his lower lumbar spine. Over the next a few weeks, he developed progressive back pain. It was unrelenting in nature, taking a lot of analgesia, which has not helped. It started radiating to his right leg, and then he started feeling unwell. A bit of fever, he had a bit of sweating. So when he was examined, he had localized tenderness over his lumbar spine. His motor function was normal. However, he did have some paresthesia over his right L5 and S1 dermatome. Blood tests revealed that these inflammatory markers such as CRP, ESR, and white cell were slightly abnormal. So he went on to have an MRI scan, which showed that there was edema in the paraspinal muscles, and also there was fluid in the facet joint on the right side L4-5, suggestive of an infection. So then subsequently was treated with antibiotics. There's another case of a 76-year-old female who has been complaining of increasing back pain over the last 4 weeks. There's no history of trauma. She's seen a GP on multiple occasions and had the increasing dose of analgesia as per the stepladder for pain management. However, it has not helped. She's got a history of COPD and has been on steroids for a long time. On examination, she was tender over her lumbar spine. The neurology was normal. However, when she was erect, she had a kyphotic deformity. So this is the MRI scan of her lumbar spine, which reveals that she had a new fracture of L4. And you can also see that she had a previous fracture of L3, which has caused some compression. I found these red flags quite consistent in the literature. I mean, there are a number of red flags I mentioned earlier, but these seems to be consistent with most of the serious spinal pathology. History of weight loss, previous history of cancer, night pain, or if somebody presents with sudden anesthesia with difficulty with micturition, age over 50 years, if they had any significant trauma, if they've been on steroids for a long time, if they're presenting with fever along with back pain and some progressive neurology, if they had a history of intravenous drug abuse, or if they're having progressive neurology. I find these to be quite significant. And if you have a patient presenting into your clinic with increasing back pain, some neurology, and with any of these red flag sign, you should have some concerns. So red flags are signs and symptoms that raise the suspicion of serious spinal pathology. The high number of red flags presents a challenge in terms of their everyday practical utility. The red flags remains the best tool that healthcare professionals have to raise suspicion of serious spinal pathology when used in combination with a thorough patient history and an appropriate physical examination. Substantial litigation costs can be incurred by healthcare providers if serious spinal pathology is not identified early and managed appropriately. In the clinic, if you've got a patient with some red flags and you have some concerns, then it would be best to be referred urgently or emergently. And these are some papers I think Joe had already mentioned, but one of them which would be quite useful in reading. Thank you. So I think, yeah, if you have any question answers, you can put it in the chat box or in the Q&A box.
Thank you very much. If I can pass on now to Gavin Clay, who's a consultant musculoskeletal radiologist in Cumtaff Morgannog, and he's going to talk about pathways and management in radiology of cauda equina syndrome.
Hi there. Yeah, thanks so much for inviting me to talk to you today. My name is Gavin Clay, radiologist in Cumtaff Morgannog, based in Royal Morgan, Prince Charles Hospital.
Gavin, sorry to
yeah,
interrupt. Your audio mic's not working brilliantly. Can you just try and adjust it a bit, perhaps?
Is that any better?
Just a bit crackly.
Is it? Okay. Can we just...
Can you hear me now?
Much better, thank you. Crack on.
Okay. Okay, yeah, so I'm going to talk about imaging and report interpretation in radiculopathy predominantly. Okay, so the mainstay of imaging for patients who present with radiculopathy is going to be MRI scanning. Of course, CT does have a place if MRI is unavailable or if it's contraindicated, and can be very useful in certain cases. In Cumtaff Morgannog, our MR or radiology requesting guidelines do really encourage the passage of these patients from primary care to the musculoskeletal triage services in the first instance prior to imaging, if possible, so they can at least get some physiotherapy input and maybe some management before we jump straight into imaging. So imaging obviously central to the patient pathway and the patient management, and basically consists of 4 stages. So stage 1 is when a request is made by yourselves, the referrers. The request is then received and justified or maybe discussed by the receiving radiology department. And that, unfortunately, can take a little while in the era of paper request forms. Obviously, that'll take a while for it to arrive in our department and then arrive on the radiologist's desk for vetting. So delays can be incurred. So if you think this is a particularly urgent case which needs imaging, then it might be worth you discussing with the radiology department directly. Hopefully, we're going to have electronic requesting throughout Wales in the near future, so that will expedite the process significantly. The third stage then will be the scan being performed and then reported. So the patient gets put on a waiting list, and the degree of urgency is mainly put down by your clinical details. So it's really important that you relay to us exactly what your concerns are, so that we can appropriately triage that patient for imaging. And then, of course, as you may be aware, throughout the country, there are often reporting backlogs. So the scan may then wait for a little while before it actually gets reported. And depending on local imaging departments' reporting processes, some of those scans may be outsourced to teleradiology companies. And so maybe a report of a radiologist you're unfamiliar with. The fourth stage then would be communicating the report back to the referrer. So whether that's via just a routine process, or maybe if there's more kind of urgent findings, that radiologists may be duty bound to get in touch with the referrer directly, either by email or actually phone, if necessary. So I'm just going to touch upon the cauda equina pathway in Cumtaff Morgannog. So this was constructed in recent months, really, in response to us not really having one, and also to litigation cases in recent years, which have, as we previously mentioned, are in the 7 figures, so are considerable. And also in response to the recent guidance by the British Association of Spinal Surgeons in terms of indications for scanning these patients with potential cauda equina. So you have an overall pathway for Cumtaff covering all 3 hospitals, which basically states the principles that clinical assessment by a healthcare professional competent assessing for cauda equina with requesting rights for MRI can then request the MR, and that can be approved by the radiologist either on duty in the daytime or on call if it's overnight. If MRI is contraindicated, then it may be up to the referrer to discuss that patient with the spinal team. There are nuances to the pathway in our separate hospitals. So RGH and PCH are very similar in that the health board physios, whether either working in community or secondary care, can refer directly to radiology for this by discussing with the duty radiologist, and then referring the patients to ED or TNO to be looked after, but not necessarily reviewed again, as we will take the request straight from the physiotherapist in that instance. But obviously they will need to take overall care of the patient when they arrive in hospital in case they need to deliver the results or manage appropriately thereafter. In POW, it's preferred that the health board physios, either in community or secondary care and primary care, so GPs, all refers directly to the TNO for review by the TNO SPR in cases of suspected cord recliner. However, we have got 12-hour, 7-day-a-week access to MRI scanning in all 3 hospitals now, which is a recent improvement actually. And in at least 2 of those hospitals, we have early morning slots available. So those patients which arrive after hours or overnight can get imaged around 7 AM so expediently as possible. And the whole reason for constructing this pathway is to obviously expedite every point of that pathway along the patient journey, and ultimately getting the patient seen quickly and scanned as quickly as possible so that the decision on management can be made. So when we're reporting these scans, obviously we need to be descriptive. We need to just say and tell you what the findings are, but obviously that needs to be understandable to you as clinicians. So you need to be aware of the terms that are used. And there are many different terms that are used by radiologists interchangeably sometimes, which may sound very different, but might actually mean the same thing. It's up to you to determine then whether those findings actually correlate with the symptoms or not, so you can decide your management. We may put at the end of the report some onward advice if we think there's anything particularly important, or maybe even red flag or red alert that report to draw your attention to any unexpected or significant findings. I'm just going to talk about them kind of less red flag type stuff, so less sinister. So we've touched on discitis, malignancy already. So I'm just going to talk about kind of standard disc pathology, which causes nerve impingement. So when we're looking at discs, these discs contain a degree of water. And as we kind of get older, the amount of water within that disc may decrease, and the disc might become dehydrated, or what we call desiccated. The height of that disc might decrease a little bit as this happens, and you may see some end plate changes, all of which are very common things to see and not necessarily abnormal as we get older. As you can see on this sagittal T2 sequence of the lumbar spine, the fluid signal within the CSF is bright, and also in the discs from L1 to L5, the central disc signal is quite bright, as opposed to the disc at L5S1, which is dark, implying a loss of water content and desiccation due to degeneration. But there's a little focus of high signal at the back, which is consistent with a small annular fissure or tear. That finding on its own may not necessarily lead to any radiculopathy, but it's when we get into the realms of disc prolapse or herniation, when traversing or exiting nerve roots may become in contact with those bulging discs, that radiculopathy may arise. So a disc bulge is a very, very common thing to see. It can either be circumferential or asymmetrical, but usually involves more than 25% of the disc circumference. A disc protrusion, by contrast, involves less than 25% of the disc circumference and has a slightly wide base, but obviously can protrude into the foramen or the canal and become in contact with traversing nerves. A disc extrusion, again, involves less than 25% of the disc circumference, but the base is slightly narrower than you would see with a protrusion, and these can be quite large at times. And this is when we get nerve involvement. So as I said, so nerves can be come in contact with discs, usually either in the foramen or in the lateral recesses where they become impinged. And there are many different ways of describing contact between discs and nerves. So abutment I'd use where the disc is just in contact with the nerve but not actually doing anything to it. Some people use the term irritation, but I think that's more of an inference really than an observation when looking at MRI scans. If the nerve is in very close contact to the disc and you're getting symptoms from that nerve, then maybe it is being irritated. I reserve the term attenuation or displacement for when the nerve is actually being changed by the disc in some way. So its course usually is being displaced as it traverses that disc or exits the foramen. And then I use impingement or compression for when the nerve actually is changing shape. So the disc pressing on that nerve is causing the nerve to be flattened or even squashed against another part of the spinal column. So usually the facet joints in the lateral recesses. Here you can see a sagittal lumbar spine T2 sequence, which shows at L4-5 there's disc desiccation with a small disc bulge, but at L5-S1 there's also desiccation with more of a protrusion. And on the axial slice at this level, you can see that this protrusion here is compressing the traversing right S1 nerve root. So if you had symptoms that were attributable to that nerve root, then that would obviously be a very good target for something like an injection. The canal does become narrowed sometimes or stenosed by these discs or other pathologies. When the canal is wide open and normal, we describe it as capacious, but then the stenosis can be categorized from mild to severe. And this is when the cord may become compressed or impinged, and when chordoequina compression might ensue. It's important to differentiate between whether your patient has acute or chronic stenosis or stenotic symptoms, and it's very helpful for us if you can kind of imply that on your request forms. We occasionally get request forms for patients who've got query chordoequina syndrome from either a primary care setting where the request has taken quite a while to land on our desk, in which case, obviously it's way too late if it actually was acute chordoequina syndrome, so or even cord compression. So if you think it's one of those things, but it's chronic, please put that on the form so that we can relax a little bit and not get immediately on the phone to the patient or yourselves. As Joe alluded to previously, we, in our last MRI user group meeting, actually discussed the use of a patient information card. So it's not uncommon for us to scan outpatients, often on the weekend, who've got big discs causing severe stenosis. And obviously these are just seen by the radiographers who are doing the scan. They're not medically trained, but they obviously have training in terms of talking to the patient about symptoms of chordoequina. Obviously, if there's any concern about that, then the radiologist will be contacted, who will then contact the orthopedic surgeons. But if there aren't any symptoms of chordoequina syndrome, the patient will now shortly be receiving the advice card to know what to do if they do start. This is a thing which I get often asked about, is crowding of the chordoequina. What do we mean by that? So as you can see in this left-hand image, we've got a fairly wide open thecal sac here with the small grey dots being the nerve roots of the chordoequina. But on the right-hand side, this disc bulge has caused all of those nerve roots to become much closer together, crowded, okay, in another word. So it's much less CSF seen between them. So there's much less high signal between those nerve roots, and we call that crowded. And this is an example of disc extrusion we've seen one already, causing chordoequina syndrome. And this is often the type of disc herniation which leads to chordoequina syndrome. So it's an L5-S1 disc desiccation, as it's darker on the T2 sequence, this big disc extrusion posteriorly. You can see here on the axial, this is the slice above, this is the slice of the extrusion, which is causing significant stenosis and compressing all those traversing nerve roots. Now, it may be that the patient hasn't actually got the symptoms of chordoequina, in which case they may not need immediate referral for spinal surgeon input. But, as a radiologist, I would certainly be suggesting that on a very urgent, immediate basis if the symptoms of chordoequina syndrome were present. This is an example of chronic stenosis. So this is where it really is important to know the different symptoms and signs of a chronic or acute stenosis. So a chronic stenosis is a very kind of long-standing thing which creeps up on you slowly. It's due to degenerative changes, disc bulging, which you can see is circumferential here, but also things like ligamentum flaval hypertrophy, this darker area along the posterior aspects of the pedicles, and the facet joint hypertrophy, all contribute to stenosis of the canal, which will be a chronic thing and not necessarily give you neurological symptoms. So not always something to get very excited about immediately. Other things we'll obviously also comment on, the alignment of the vertebral bodies, where there's a scoliosis, either degenerative or congenital, anterolisthesis or spondylolisthesis, either due to degenerative facet joints or pars defects, and then things like muscle bulk and everything else we can see, basically. So we obviously can cover some organs when we do spinal imaging, as well as the marrow signal for any kind of sinister causes. So in summary, there are multiple different terms for lots of different conditions or findings, as you can see on MRI scans, and many of them may be irrelevant and obviously all increase with age. So just be aware of what you're looking for and be able to interpret that report and act appropriately if the findings do correlate with the patient's symptoms. Again, just to re-emphasize, please let us know if you think the stenosis or the symptoms you're dealing with are more chronic rather than acute, and don't get too panicked if you see a severe stenosis, if we think it's chronic and you think it's chronic rather than being acute in nature. Okay, thanks very much.
Thank you, Gavin.
Stop sharing now.
We've just a few questions that have come in through the Q&A session that I think would be timely to answer in this session. If I can direct the first one to Gavin, and this is two questions combined in one. You may have seen the statement added to the reports, radiology reports proposed in NHS England in terms of normalising age-related findings, as well as providing clinical information on a radiology report. Is there any plans in Wales to adopt this move?
Yeah, sorry, I missed the first part of your question there, but I know what you're talking about. So I was contacted by NHS England individually to ask about this, and then the question also came through to the British Society of Skeletal Radiologists very recently to be discussed on the forum. And I must say, I've got a pretty negative opinion of it, to be honest. I don't see the value of adding a paragraph like that to every spinal report or even every lumbar spine report. It kind of goes without saying as a radiologist that all radiology reports should be correlated with the patients that's in front of you. And I think putting a kind of sweeping statement like that would not necessarily benefit the clinician or the patient. But I do think, there's a place for knowing that, and that might be better placed in the pathways that we produce, in general knowledge of clinicians that, a lot of findings may be present, but not necessarily relevant. And I think it's much more important to improve education and knowledge of clinicians and referrers, like I've tried to do just now, really, as opposed to putting a wide sweeping statement on every report, which is going to be a bit meaningless. You may get difficulty with compliance from radiologists. You're going to have to involve all the teleradiology companies, which do a lot of imaging reporting of spines in particular. So I think that concept will be difficult for radiologists to accept, and certainly there's no it hasn't been discussed in Wales.
Thank you. This is a question for Mr. Modine. For patients with cauda equina, are you concerned about any changes in bowel or bladder, or are you looking at frank urine retention or bowel incontinence? So what degree of concern do you put about bladder and bowel patients' reported symptoms?
So with cauda equina, there are different stages. So you have cauda equina suspected, cauda equina incomplete, and cauda equina retention. So in the phase of cauda equina retention, patients will have a painless bladder retention, and they'll have a overflow incontinence. You want to try to catch them early, because once they've gone into retention, again, they're depending upon the time from retention to your intervention. The chance of recovery can be variable. So any changes with any bladder or bowel symptoms, I will try to act on that rather than waiting for the retention stage. We have adopted quite a few red flags within our criteria in Cardiff and Wales, where patients who present to A&E, they have some cauda equina performer. We look at any urinary changes in terms of the symptoms. And then if we identify that they've got some perianal numbness, or if we think they are highly suspicious of cauda equina, we also do a bladder scan. And studies have shown that any pre and a post-ward bladder volume, and if you have a post-ward retention of more than 200 ml, that is found to be highly correlate with cauda equina syndrome. So if we tick any of these boxes, we would scan them.
Sorry, I'll chip in as well. I think, Naz, you make a very good point. So this is what we've put down on our local cauda equina pathway. So you can see, bilateral sciatica being one, acute urinary retention or incontinence, altered perianal sensation. I can see there's a question about saddle anesthesia, fecal incontinence, limb weakness. So all these things, loss of anal tone. And then we rely on the problem is all these symptoms are so subjective. Now, if you look into the general population, with due respect, it's not uncommon to have incontinence, and perhaps 30% or 30 to 40% of the adult population has got a degree of incontinence for different reasons. And I don't want to go into male-female ratios in that, but that is there. So unfortunately, it'll be difficult to sift all that through. But if they have got all these symptoms, then you got to start thinking, and that's what it is, isn't it? That's a red flag. And we know that nearly 85 odd percent, 80 to 85% of scans that we do for suspected cauda equina are negative. But we still do them, right? And I still get a phone call late in the evening, middle of the night, whatever time, and they go, potentially this is what they have. I'll say, just scan them, right? Because on one hand, you could say leave it, and then you've got something silly happening afterwards. It's better to clear it off. And once the scan is done, we're done and dusted, we're out. We can make a decision, we can move on. All these symptoms that are there do not have any high sensitivity or specificity. The one which has got a better predictive value is the bladder scan, which can only be done in a secondary care setting, can't be done in the primary care setting. It may be difficult to even do a PR in the primary care setting, right? So unfortunately, you just have to ask simple questions with regards perineal numbness, with regards bladder bowel. Can you feel the toilet paper when you're wiping your bottom, right? Do you have any numbness in your private areas around your bottom? All those sort of things. And if you have any suspicion, then they get referred to. That's what the red flags are there for, right? So this is what we set up. And then, as Gavin rightly pointed out, they'll get scanned, and then how they get triaged from there on is the next step. But that's more for secondary care rather than primary care. But I think from a primary care point of view, these features that are there are important to take on board. Sorry.
Yeah, no, that's fine. I think the bottom line is have very low index of suspicion. If you worry about cauda equina, just scan them. I think it saves a lot of time and money with terms of litigations and other problems that can come on later on.
I think Kumta, I was there a couple of years ago talking to my orthopedic colleagues. I think there are 2 or 3 cases going on there. I know in Gwent there are 2 or 3 cases going on there. I know we've had some. Like, nobody's immune to it. These things happen. But that's where, if your index of suspicion is high, you have a very low threshold to investigate. Once you've investigated, then you can sleep easy. You can rest and relax and say, this isn't it. Gavin, would you agree with that?
Yeah. I think even in the last 10 years, I think there's been a payout of at least 25 million for cauda equina the last 10 years in UK alone.
Yeah, I agree. I mean, I think I'm obviously perhaps one of the more sympathetic radiologists to this condition than many others would be. And there's quite a bit of fight back generally, I think. And this is why it's so important to employ these pathways so that ultimately we have to do them. If you've got a suspicion, then there's no real reason for us to say no to those. However, the pathway has caused a massive burden on our MRI scanning capacity now, and we're getting a lot more quadrant scans done now than we were several months ago. And although you mentioned about 80% are not positive, I think a lot of them will have findings, but very few will have cauda equina lesions, in the realms of like 5 to 10% probably. So I think, we are scanning a huge amount of patients now to find the patients with cauda equina. But, like I say, I'm sympathetic to that, and I'm aware that a 7-figure litigation case is a new MRI scanner, right? So why would you not? Okay.
So on that note, Gavin, you make a good point. So I remember 2005, I went to Carmarthen for a meeting, and I was sitting and talking to them because there was a case of cauda equina which they were trying to refer to the neurosurgeons on a Friday. Patient comes in at about 2-3 o'clock. In West Wales, if anybody's worked there, they know their MRI scanner used to be in Prince Philip. So by the time they called up the MRI guys, they had all finished about 4:15, 4:30, and they were gone. So they couldn't scan the patient till Monday morning. This patient had a full-blown cauda equina, 34-year-old patient. Monday, they confirmed it, went to neurosurgery in Morriston. I think they were stung 1.5 million. Now, this is 2005. Of course, there's a lot of escalation on that cost. And that, it was 3 million. And that's what the medical director said to me. We could easily have a scan and recurring funding for a radiographer to be there to man it. And that's what happened. They bought a scanner for Glangwili because they didn't have one on that hot site, because the scans were being done in the cold hospital. And I could tell you story after story. Even during my career, I've seen the radiologists used to ask a question: have you done a PR? Have you looked at the perianal sensations? Nothing like that is asked anymore, right? If there is a doubt, you just get the scan done. And we were stung for 1.5 million by somebody who wasn't scanned that night, did not actually have a cauda equina, but somewhere somebody said something to that effect. That's a different story altogether. But that, if as Gavin says, you got to be sympathetic to the symptoms. And once you scan, okay, 80% negative, but then it's done. It's done. You're comfortable then.
Can I just say one thing as well? Really, when you're making a decision about the scan, though, it's not on one thing alone. It's a combination of a number of symptoms and an objective examination. And that, in the framework, it said it's not just one thing that raises your index of suspicion. It's the whole picture of the patient.
Correct. So I've put the National Cauda Equina Pathway Framework in the chat. And the other thing, the question was about the symptoms, which I think Gavin will answer again. But there was a recent paper on catastrophization of an MRI report, which I've just, it's good reading. So yes, I think there was Helen, you got a couple of questions, isn't it, about the MRI reports?
Yes, I'm conscious of time,
right, okay.
and we'll answer some of those later on, but I just have one last question for Gavin because it's pertinent to this session. A question from somebody in CTM, just wondering, can a therapist without imaging rights refer to the duty radiologist for an emergency MRI scan if CES is suspected?
We have quite a good relationship with a lot of the physiotherapists in Cwmtâr, I think. I think you have to have requesting rights to be able to request that MRI scan. And if you haven't, then you can't really. So in that case, that would either be referring to your colleagues who can, or referring to orthopedics. If you can't actually if you're not allowed to write that form out, then you can't do that now.
Okay.
But on the other hand, if you're convinced, send the patient to A&E.
Yeah.
What's wrong with that?
Yeah, orthopedics, A&E, or your colleague.
Yeah.
Thank you. If we move on now to session 2, keep on putting questions in the Q&A session, and we will ask them at the panel session at the end. If I can move on now to Rob Goldsmith, who is talking about physiotherapy management of sciatica. Thank you, Rob.
Okay, can you see the screen there okay?
Yes.
Fantastic. So I'm going to give you a little bit of talk on physiotherapy management of sciatica, or to put it another way, how to help someone with sciatica without needing knives, needles, or tablets. Now, why did I call it that? We sometimes really do need knives, needles, and tablets. They're powerful treatments, and with the right patients, they're exactly what's needed. But generally, I do get the sense that as physios, sometimes we're not sure how to help, or we lack confidence in what we can offer. And I think that's a shame, because I think we've got a key role to look after people who are not appropriate for those things. And so I'll try and help with that in this talk. We're going to cover the following areas. So I'm not going to cover the basics of physical assessment, which I'm sure you already know. Similarly, I'm not going to go through great detail on exercise prescription, which can be reasoned from various perspectives of mechanical compression opening patterns, or physiology of blood flow and inflammation, or a patient-centered functional approach. But in this talk, I'm going to talk about these various areas, how to listen to someone, how to examine them meaningfully, how to teach them and to understand what's happening to them, and help them build a plan, and when to involve somebody else in their care. So if we're going to establish a relationship with someone, which we need to do, and then, well, how do we do that? Well, patients will often arrive at your door probably quite distressed, frustrated, probably not having slept very well for a period of time, and they really need you to see that. So this isn't just tea and sympathy, and it's not a waste of time. I tend to find if you skip or dismiss this section, you'll probably just receive more distress as they attempt to show you how painful or hard it's been. So even if you look at it from a timekeeping point of view, this is quicker. We did a little study in Cardiff looking at a qualitative interview study, and I'm going to let you read the quotes from some of the participants. We asked what it was like to have sciatica, because as an exercise in empathy, I kind of want you to imagine it's you saying these things, or perhaps someone you care for, like a partner, a child, or a parent. Imagine this is them. So pain is part of life, but this is different. There was a range of people and demographics these quotes came from teenagers to people in their 50s and 60s, from people who are long-term unemployed to people who own their own businesses. So in terms of an illness experience, it's severe, it's unpredictable, it's draining physically and mentally, and there's an overriding feeling of the pain not being visible. And roughly a third of the cohort had at least entertained thoughts of suicide. So if we do that, what does that look like? Well, sometimes patients will tell you quite easily, sometimes you have to kind of encourage it out of them, and there's some nice tips from Lisa Roberts using TED questions. Tell me about this, explain what it's like to have that, describe how this has impacted on you. Those kind of word stems in your history are quite powerful. Really try and imagine it was you, and I literally want you to try and involve your sensory cortex and imagine that was the leg pain going down your leg. And it's really important that we believe them, and we say that the pain is real, and we do that without using the word but. Your leg pain was terrible, but is pretty dismissive. And I think this kind of builds a relationship and allows you to quickly move on to areas that are probably more helpful to actually make progress with them. Okay, assessment wise, if we're going to perform a meaningful assessment, we need to do a few different things. So we need to do a meaningful assessment that addresses your concerns over what type of leg pain it is it a red flag, is it something else, but also their specific concerns. So if they arrive at your door with questions of, is it cancer versus why does my leg feel on fire, why is it all feeling numb, or will I ever be able to sit down or sleep properly again, our assessment should reflect that. We're also going to want to have a look at some sort of nerve health. So what state is that nerve in? We can look at patterns and triggers of pain to help identify that, and just get a sense of what the patient's after from us. What are their overall goals and function? So what type of leg pain? There's obviously various types, and we've got these terms that we use regularly, and they all relate to spinal pain referring into the leg, but we need to be clear about what we mean. So sciatic pain is a sort of dull diffusing pain caused by convergence in the dorsal horn, whereas radicular pain is much more unpredictable, electric shock shooting sensations, typically coming from compression or inflammation causing these ectopic discharges. Whereas radiculopathy is really a loss of function in the nerve, loss of sensation, power, or reflexes. And interestingly, these aren't always painful. Quite commonly, patients will experience very severe early pain, and then the pain will rapidly disappear as the nerve deteriorates. And this may be a mix of neuropraxia with essentially stunned nerves versus axonotmesis with the axon itself being disrupted. There's a really nice categorization of this that's available free online in Wheeler's textbook from Anina Schmidt and Pat Tamplin. And we can look at the neuropathicness, if you like, of the leg pain. So the middle ones here are all the referred leg pain groups. Radiculopathy with a loss of functions over here, and these are the back pain groups over here, some of which we think may be neuropathic, whereas somatic pain is mainly nociceptive in function, maybe a positive straight leg raise or slump here, but true radicular neuropathic pain over here. And what does that look like? Well, this is quite an old study based on some hypertonic saline injections. So Kellgren injected various soft tissues in the spine that were nowhere near a nerve, things like multifidus or some of the interspinous ligaments. And patients mapped out these sort of diffuse somatic symptoms over here. And if this blue one is the S1 somatic symptom, and we compare that to an S1 radicular pain, you can see the difference, these nice clear delineated line down the back of the leg. But in reality, they coexist, and we have a more complex picture to tease apart. I'm going to skip over the actual assessment bit because the basics are quite simple, and this format's not a good way to show this, but we do need to exclude leg flag pathology you've heard earlier in the talks. We do need to get assessment of nerve health and sensation, power and reflexes, and straight leg raise to look at how sensitive it is to mechanical deformation. And if appropriate, and we're looking for an intervention target, then perhaps an MRI. In very rare circumstances, we'll consider nerve conduction studies, but that's extremely rare. There's some interesting research work going on looking at the role of small fiber assessment to do with temperature and thermal thresholds. and measuring inflammatory markers, but for now they remain really a research area rather than something we can use clinically. Is it something else? I'm just going to skip over this because it's covered in early areas, but essentially we're looking for something else. Is it hip, hamstring, SIJ, something else that's giving that nociceptive pain, or something more sinister? In terms of nerve health, we can look at loss of gain of function, and I think that makes the most sense to us. Is it sensitive? Is it not functioning? But I think some of the other factors here, I think, are much more interesting. These modifiable factors that may also be presenting. So we need to assess for these. All these things can affect nerve health in various ways. So that should form part of our assessment as well. And we can plot this on a diagram that some of you may remember from physics, a sort of vector diagram. This has been suggested by Matt Lowe and from original work from Anuj and Munford. And we can put the negative things on one side, but we can also put some of the positive things on the other. So if someone has got poor sleep, but the GP is trialing some amitriptyline to help with that, they've got diabetes, but they're also on a treatment for it. So we can plot those both on, and we can try and quantify them. So we can try and give them bigger lines for bigger effects. But we don't need to be limited to just nerve health, and we don't need to be limited to just the biomedical field. We can put on some of the social factors on here. So the stress coming from work, and we know that affects nerve recovery, but they've got a supportive employer, that's a positive aspect, and we can plot those on as well. So we can kind of do that as we're going through our assessment, either in a head or sometimes even with a patient on a piece of paper. What about patterns and triggers? Well, neuropathic pain is unpredictable, it's inconsistent, it's illogical, and in many ways cruel. We need to help them predict that. So we need to predict the unpredictable. Think positions they're in. Is it in a neural tension position? Is it a neural compression position? Has there been relative stressful events that the patient recognizes triggers more symptoms? Is it down to the speed of the movement? We need to help them make sense of the chaos. And the first part of that is identifying what triggers their symptoms. A meaningful assessment should include what they want to get out of it. So if they can't sit down, we need to help them with that. If they can't sleep, that's a priority. And if they can't control their unpredictable neuropathic pain, we need to help them do that. And that becomes increasingly important when we're dealing with recurrent or persistent leg pain that is generally, on the whole, less likely to respond to other interventions. And we can, to bring that to life, we can look at the World Health Organization model of impairment, activity, and participation. So, for example, someone with a right L5 weakness with a radiculopathy of the foot drop can't run, which means they can't play football with their son. And that's important because they're divorced and they only get 3 hours a week time with their son, and all they want to do is play football. So we can look at the whole person and build that picture. If we're going to try and help them understand what's happening, we kind of need to use everyday terminology in their language when we're explaining these things to provide an inbuilt reassurance and an honest prognosis. If you think the pain is going to be long lasting, then we perhaps should say that, and we shouldn't shy away from that. Sometimes it's not great delivering that news, but patients do need to hear it if that's the truth. It's not imparting information or showing off. It's helping them make sense of what's happening to them. And if we're going to do that, we need to understand what radicular pain is and what the pathology is. It's bizarre, and we need to help them understand that. It is complex, but this is probably the best diagram I've come across, which is from Louis Gifford. And I think there's nothing that I've learned more about radicular pain which changes this dramatically. Essentially, we are looking at mechanical factors, which could be quick or slow, which will affect the nerve root or the dorsal root ganglion, in which case we'll get immediate responses. But that will also have secondary effects on the vascular system, both inflow and outflow with venous and arterial systems, creating a form of ischemia, as well as a chemical irritation from leak material from the nucleus. And that will lead to intraneural physiology changes, edema, inflammation, fibrosis, and nerve fiber damage and dysfunction, and these ectopic generating sites. And that kind of explains quite neatly the range of symptoms that patients will display. We can add some more science around this now. So we've got some more information on ion channels responding to tissue acidosis and mechanical force and inflammatory mediators. It's not completely understood, and it's complex, it's multifactorial and quite individualized. But if your patient's displaying a certain symptom, we can link it back to this now. They don't need to know the ion gates, but to know that there's an understanding for why the body is behaving in that way. How do patients rationalize their experiences before someone tries to help them? Well, we asked that in the interview study as well. And essentially, it's very compression focused. Unless we explain it in broader terms, they'll just think of compression. And that's not a problem if you're planning on decompressing the spine, or you're expecting the symptoms to improve if the disc does indeed shrink. But that's not always the case. Sometimes the disc will shrink, but the symptoms will stay. And many people will improve, but the compression remains the same. So while it's there, it's a helpful thing for the patient to see their pain on an image. But when it's not there, it becomes extremely confusing. And these are the group that are often hardest to manage. People with disc concordant scans need two things. They need validation, and they also need a thorough examination to make sure that we do consider the potential other extra spinal causes of neuropathic pain, which may or may not be there, but we need to make sure that we've checked thoroughly for that. Ultimately, we're trying to arrive at a shared meaning and a narrative to explain the symptoms. What bothers patients? So this is a nice study from Norway, and it's looking at bothersomeness index here, so how bothersome the symptoms are. And it's not just at leg pain, but also at paresthesia and weakness. And we can see for prolapse intervertebral disc populations with a first-time leg pain, the majority of those symptoms will recover quite nicely in the first 3 months and then steadily off. So that 3 month timescale seems quite realistic, and we can be quite optimistic with these people. However, if we recruit from primary care-based studies, which will include a clinical definition without an MRI, then and will include people with acute, recurrent, or chronic symptoms, the prognosis is nowhere near as positive. We can split people up into 4 groups roughly, and there is a group that will eventually have a late recovery, but it's an extremely small group. The majority of people are in the other groups. And you can see here, again, around the 3 months, they've had improvement, but then they're stabilizing more or less. Certainly these 2 groups here are not improving. So how do we help these people in the purple and red lines here if the symptoms are not improving? Well, we can do these things. We can help them cope with the here and now. We can help improve the nerve health. We can avoid triggers with them, and we can add buffers both to them and to the nerve. So how do we cope with pain? Well, medications is not a dirty word. It's a good thing, but we just need to be careful, particularly with the opioid use. It's nice to add to that. So it's a multimodal plan. So maybe some topical analgesics, capsaicin creams sometimes used for the strongly dysesthesic pains, or we can look at some of the thermal treatments, things like hot and cold treatments, or even relaxation tools to cope with symptoms. Mental health, there's some population here we do need to take good care of, and you do want to know the numbers of your community mental health teams before your patient tells you they're going to go home and take all their medications. Sleep is another factor that's very important. We need to get them comfortable but slightly physically exhausted with exercise during the day that's achievable for them, so they feel like they want to sleep. Avoiding caffeine, stimulants, and alcohol before bedtime, and having a bedtime routine of avoiding some triggers, using sensible medication, some stretches, a hot bath, reading a book, going into a cool bedroom, plenty of pillows to adjust positions. Daily functions, how are they going to cope? Who picks up the kids from school? Who does the shopping? Do they need to get a delivery for a couple of weeks just to cope? And just especially in the early phases, small steps, there's no rush here. We don't have to push these guys back to work straight away. It's a process the nerve needs to go through in some cases, and bed rest is okay. We're not dealing with back pain here. What about the other things? So we could do some of the other things, but what does that look like? Well, we can go back to a diagram here. So we put on some positive and negative factors, both biomedically but also socially as well. We can add in some tips to sleep well. So we can look at the sleep hygiene we talked about earlier, and that will help improve their sleep. We can make sure their insulin medication has been taken regularly and has the right dosage with the GP. We can give them other means of managing stress. We can get them to see their friends, breathing exercises, meditation, whatever is appropriate, which will help them reduce their alcohol intake. Make sure they're taking their supplements if they're prescribed on a regular dosage. We can look at that supportive employer and look at them adapting their work duties or hours. And already that's a much more positive picture than the one we started with. What else can we do? Well, there's some limited evidence that moderate cardiovascular exercise may have a role to play in nerve recovery. And we'll need to facilitate that. So we need to make sure, for example, if you're going to do an exercise bike, that first of all, that they're not sensitive to flexion, but also that they're comfortable on the bike, the stretching program before and after. So we make that easy for them to do. This comes from a patient representative called Tina, and I'd really thoroughly recommend her website here, both to have a look around yourself, but also to direct your patients out. I regularly use it with patients. And these are all the things that Tina's living with long-lasting neuropathic leg pain, and that she's built up to understand all the things that influence her pain. I won't go through it in detail, but do use it as a resource. It's fabulous. And this is Tina's plan. This is how she's mapped out the things that she's doing to cope with that long-lasting leg pain, that nothing seems to be helping. So lastly, what do we do about involving other people? Well, we need to know when to involve surgeons in A&E. We've talked about A&E already, but what about surgery? Well, there probably is an opportunity to help nerves when they're going through an acute disc prolapse. And there probably is a surgical window to decompress the nerve or use a root block to reduce the inflammation response. And if we miss that, we may well end up in an irreversible state for that nerve, and we need to minimize the number of patients achieving that end stage of nerve fibrosis or damage that's permanent. So when we have got those acute disc pathologies, we need to consider when is the right time to intervene. And we've set some pathways up locally to try and hit those interventions to make sure we're investigating at the right time to allow intervention to happen at the right time, be that root block or surgery. We need to use our GPs judiciously. So GPs know their patients and they will be looking after those patients long after we discharge them. So we need to share our thoughts on prognosis and the long-term plans for coping with them. As I said before, we will need to know when to refer to mental health services. Better to know the numbers before than be it too late when you wish you knew them. It's really important we don't dump on pain management services. They can't fix our patients any more than we can, but they can be helpful in putting together a comprehensive plan when it's a particularly complex presentation. Use them wisely. When you have a specific concern, that's a good option to involve them. This is the pathway that we've developed locally. Now Sasha in the intro gave me all the credit for this, and I just need to flag that it's not me. It's one of my amazing colleagues, Rian Jenkins, who's championed this locally with us. And what we've managed to put together is that our FCP colleagues will look to optimize supported self-care as a first-line response. The option to escalate to therapy support with us with exercise, manual therapy, and coping mechanisms. And if appropriate, we then have options to think about imaging to accessing nerve root block with our radiology colleagues. We've got a fast-track pathway now to achieve this for a severe unremitting leg pain that's lasted at least 6 weeks. And that also means then we can access reasonably fast imaging to identify a level. And that also means then, if required, we can have a virtual clinic consultation with one of our surgeons to optimize surgical care. But we're trying to achieve that within about a 3-month window. So we've put these informations out to our FCP colleagues and also our core staff to say what we're looking for, when to consider fast track imaging. It's got to be severe leg pain worse than back pain. It has to be neuropathic. It has to show little or no improvement at 6 months for leg pain, perhaps a bit longer for arm pain. And that they're willing to consider further intervention, i.e. block or surgery. If they've got those, then we scan relatively quickly, and we've agreement with the local pathway with our radiology colleagues who are happy to prioritize these for us and get them done within a week. And these can then come back and we can have a discussion over whether there's a treatable target that with injection and root block. And what we're finding anecdotally is when we get this right with severe leg pain, we can make very big differences. We can have leg pain coming down from a 9 or 8 out of 10 to a 3 or less in short order. And it also facilitates that faster discussion with a consultant at around the 3-month point, which we think is optimal. So we talked through about how to listen, how to examine someone meaningfully, teach them how to understand what's happening to them, help them build a plan, but also know when and how to involve other people. Just flagging up some resources. There's the website I mentioned earlier from the patient representative, which is excellent. Tom Jessen's done some fabulous work on this. If you're looking for something a bit more basic, I'd recommend his email mini course, which starts off from quite a beginner level, but is really, really good. And there's a great patient leaflet produced by Alan Dobson, which we've adapted. He's happy to share as long as we rebrand and acknowledge his artwork with it. Thanks for listening. I hope some of that's been useful, and happy to answer questions. Perhaps put them in the question and answer box, and we'll get around to those at the end.
Thank you very much, Rob. That was very informative. And if you're happy, if you're able to put any of those pathways in the chat function for people to have a little look at a later date. Oh,
yeah, we'll do.
Thank you very much. As Rob said, if we can put any questions in the Q&A box, and we'll aim to answer them after the next 2 speakers. If I now pass you over to Francis Brooks, who's a consultant spinal orthopedic surgeon, who will talk about secondary care management of radiculopathy and may answer some of the questions that are already appearing in the Q&A box.
Thank you. I'm just trying to, my laptop's playing up with my PowerPoint. Bear with me. There's a question in there which hopefully I will answer, John. This. Where is this? This one. This talk. There we go. So let's go back to that. There we go. Good. My screen now.
Yeah, we can see it.
Good. Let me just launch my presentation. So my name's Francis Brooks. I'm a consultant spinal surgeon working with Mr. Ahuja and Mr. Moydeen and Joe in Cardiff. So I previously worked in Anira and Bevan, and then sensed the impending global pandemic and jumped across to Cardiff in January 2020. So I'm going to talk about some of the evidence behind what we do as spinal surgeons, and hopefully that will illuminate you on when we think about surgery, when we want early referrals, and what's the evidence behind some of the conservative measures that have been spoken about. So when we look at radiculopathy, it's very difficult not to speak about Wilco Poole, and he was one of the first people back in 1996 who decided to look at what made patients or how patients responded if they were left for a bit longer without surgery. So he had two arms. In one arm, surgery was performed within 2.2 weeks on average of the patient presenting to the spinal surgeon. And then the other arm was a prolonged conservative arm, where the patients were taken off, had ongoing physiotherapy, had painkillers, were treated. And what they found was actually in that arm, only 39% of patients ended up requiring surgery, and that was at an average of 18.7 weeks. So this shows that large proportion of these patients may still be able to be managed with a conservative course in the first offering. And that's where a lot of our change in thought process around waiting 6 weeks to get an MRI scan. And he also looked and was able to show that the vast majority of these patients don't require to go on to surgery. So therefore, in a resource such as the NHS, we have to be a bit more cost conscious, and therefore, unless there's a good indication, be it the red flags that Mr. Moydeen spoke about earlier, then earlier MRI scan is not going to serve these patients of any benefit, because the vast majority of them are going to settle. Building on to that, the main lumbar spine study was formed, and this was a cohort study set up, and they followed the patients up to 10 years on longest follow-up was 10 years, and they managed to do really well in this. It was two arms, operative and conservative, and they had around 507 patients, which was reflected 84% of their follow-up. And what they found was at 10 years, those that had undergone surgery, 25% required a further surgery at the same level. They also found that about 25% in the conservative arm had switched over to surgery. And they found that in both arms, regardless of treatment, there was a significant improvement compared to their baseline. However, they found that the time to that was significantly quicker and swifter in the surgical arm. And this kind of gives some basis to offering these patients a surgical surgery for their symptoms. However, it is appropriate, and it can still be found that conservative treatment will help in the long run for these patients. And this sort of the benefit of surgery was found in this study to be lost by about 2 years. So that's what time the conservative group kind of came back to fit with the operative group. And we found reasons for operation tended to be younger patients who were in slightly more bothersome symptoms at start off, which obviously kind of makes sense. If you've got a lot of leg pain, you're more likely to choose to go down an operative route to try and get rid of it than if you can cope with it and you're able to keep on working. The other big study was the sports study, and this was set up by Dartmouth College in the US. They set out to look at 3 main conditions: lumbar disc herniation, spinal stenosis, and spondylolisthesis. So they assigned 3 groups to the disc herniation. They had a randomized control arm, and then they had a cohort arm as well. So in the randomized arm, they had 50% of patients were assigned to conservative treatment at 3 months, and 50% were assigned to surgery. And they found that there was a high crossover in the conservative group. But then when they looked at the cohort study, which weren't assigned treatments, they found that actually the results were quite similar. Again, the results were slightly more favorable towards surgery at all time periods, but there was never any significant statistical difference in this study. Oops. So what they found, they published their results at 2, 4, and 8 years. And they found overall that there was a recurrence rate of around 11% in these patients, regardless of the treatment methodology. They found that over 50% of those patients, all related, I think it was 59% related to L5S1. And the mean time to surgery differed in the cohort group, whilst it was around 7.4 months of symptoms in the randomized group, which is actually slightly longer than you'd generally expect. So the long-term results showed that there was a significant improvement in operative group at 8 years compared to non-operative, and this did just about reach statistical significance, but there were equally a large portion of the non-operative group who were looked at with the intention to treat analysis. The most important thing that this study came out in favor of was that actually spinal surgery for lumbar disc herniation is a cost-effective procedure. They found that when they looked at loss of earnings and the cost of the treatment, that you ended up with a QALY for spinal surgery per year of symptoms of about $70,000, which is a significant sum of money. And therefore, there is a good argument that surgery should be considered for these patients if they are fit enough and if their scans correspond to it. So lots of studies try to predict why conservative treatment of radiculopathy could fail. And they've come down to 3 main things that keep on getting mentioned, which is the duration of the symptoms. So if patients not responded by usually around the 12-week mark of symptoms, then they're unlikely to respond to conservative measure beyond that. Fragment size has been spoken about, but has also been disproved to be a factor. So the argument here is that a large disc fragment would suggest that surgery should be done and that they're less likely to respond to a conservative measure. However, I've got some papers later which will show that this isn't always the case. And then sequestrated fragments were found to be worse for not improvement with conservative measures. So one of the big issues that we have at the moment is obviously going to be a massive waiting list for spinal surgery as a result of one of the many negative impacts that COVID-19 has had on the health service. So there are two papers which were shown that one by Quan et al., which came out of Vancouver, and this Charles Fisher Spinal Group out in Vancouver. They found that waiting longer than 12 weeks negatively impacts on the outcome of surgery at 6 months. The reason why this is of interest is the Vancouver or the Canadian Health Service is very similar to the British Health Service, and therefore that would correspond that we maybe should be seeing these patients a bit quicker, like how Rob is trying to improve it in closer working relationship with ourselves in Cardiff to offer surgery in a more timely manner. And more recently, Sagittal et al. Found exactly the same. I think that was published in Global Spine in 2020, that actually the longer you wait, the worse the outcome. Now, since we're talking to a group of physiotherapists, I found this paper which showed that physiotherapy can actually, according to this paper, reduce the size of lumbar disc herniations, which I thought was quite interesting. It was a very small study. They had 20 patients in each arm, so I'm not quite sure it's appropriately powered to prove their argument. Nonetheless, there is a clear role for physiotherapy. Now, in terms of injections, the literature on injections is quite mixed, so a lot of it comes from the pain clinic guys. This is a study that Mr. Hooger and myself did when I was a trainee. And we looked at 236 nerve root blocks from both public and private healthcare settings for disc herniations. We found that on those 236, around a third of them after the injection did not return for within 2 years of that injection. However, 2/3 of those patients did still progress for surgery. The reason why it wasn't published is that unfortunately we didn't have complete data in terms of pain scores and ODI for all of these patients, so it made it quite a bit more difficult to interpret the results than we would have liked. But it does show that actually an early injection has potentially a huge benefit to these patients in terms of reducing some of that inflammation around the nerve with the steroid and giving them some sustained pain relief, may allow them to complete a better course of physiotherapy and conservative measures to allow them to avoid undergoing surgery. So one of the things that is vital and is important is early referral around foot drop, either with or without leg pain. And we believe that this should be referred early to a spinal service so we can discuss it. There have been occasions where patients are referred with 6 months worth of a foot drop, and that may be due to late presentation of the patient or just management elsewhere. And this is obviously an less than ideal situation. Patients with large discs, I think, could be at risk of cauda equina syndrome and developing problems around that. So early referral for those should be appropriate. An early referral for injection, whilst it may not change the course of disease, our study does suggest that it may prevent them requiring surgery, which can only be beneficial. When we look at foot drop, we know that foot drop is not going to do well with surgery, whether they've got pain or not. The best outcome I was able to find in the literature is a 61% recovery, but the general acceptance is that around 50% of patients with foot drop will not have any improvement in their weakness after surgery. And the main reason that you potentially are offering them surgery is to try and give them that environment to recover and remove any pain. So painless foot drop is a difficult and different beast to deal with. Just to this was a scan that was able to steal off the internet. It shows a patient who's got a large disc who was managed conservatively and had significant resorption of that disc to almost back to very little irritation in that lateral recess, and it shows that conservative measures can work. And we all have similar patients that have come across, and Sashin can correct me if I'm wrong on this, but I think they looked at their waiting list and found towards the ballpark of over 2 years, around 50% of large discs resorbed. Onto large discs, we do know that as I said, that there is some evidence that the size of that disc can impede on the success of non-operative. However, Benson et al. Have published their study that showed at 7 years that they had, I think they had around 40 patients with a large almost canal filling disc that were managed conservatively with no return of symptoms. And this was regardless of whether that disc was resorbed or not. So hopefully I haven't confused you. It's not quite as scientific as Rob's talk, but hopefully it's been of benefit to you. And I'll take any questions that you have.
Thank you very much. If people can put some of their questions in the Q&A session, and we'll answer that just after our next speaker. If I hand you back again to Gavin Clay, who'll be talking about management of radiculopathy from a musculoskeletal radiologist point of view and other interventional techniques that they employ.
Hi there. Just going to share my screen again. Okay. Yeah, so I'm just going to give you an overview really of what we do when we get asked for injections, and talk a little bit about the process, etc. So the mainstay of the injection that we're going to do would be selective nerve root blocks, really, and I'm going to talk about those. So we can do those at all levels in the spine, cervical, thoracic, or lumbar. In Cwmtar Morgannwg, where I work, but the bulk of our injections are lumbar. I occasionally do thoracic, but cervical tend not to be done by us. There is a couple of people in the pain team who are doing them under ultrasound, but most of those I think would be done in Cardiff, and certainly not by our radiology department. So the indications for nerve root block, as we've discussed already, really, so failure of conservative management. They can be a diagnostic to determine whether the nerve being impinged on the scan is actually the one causing the pain, or even if there isn't a nerve or target, if the pain seems to be coming from a particular distribution, it can determine whether that is correct or not. And if there are multiple nerves being impinged, then we can always stagger those injections. So do one at a time to give a bit more diagnostic outcome. But obviously, what we hope to do is be therapeutic at the same time. There is a problem with being selective in that sometimes there is some spill of medication, anesthetic and steroid around the thecal sac, so you may get other nerves getting some benefit from that injection actually, but we'd hope to try and target the nerve which is asked for. So we can do them when there's pain with a target. So if there's confirmed impingement on the scan, either that be by a disc or if osteophyte, subforaminal stenosis, or even tumor sometimes, or pain without an obvious target, like I mentioned, if you want to have a diagnostic type test. But we wouldn't really do it for back pain. And the two main methods we do this by, one by using fluoroscopy. So the patient lies prone on the fluoroscopy suite with a C-arm which rotates around them. And then also in CT, and we use these interchangeably, predominantly just for the capacity reasons. CT is obviously better for the more tricky nerve root blocks, and sometimes a fluoro-guided injection might get converted to CT, or we may even suggest requesting it under CT guidance when we report the scan if there's a particularly difficult looking injection to do. So the process is the patient arrives, I discuss with the patient their current symptoms. Obviously, if their symptoms have resolved, then there's no need for the injection. Go through then the written consent, which I'll talk about later. Patient, as I said, lies prone for about 10 to 15 minutes on the table, sterilize the skin, and place the needle next to the nerve root and deliver the corticosteroid mixed with a small amount of anesthetic. We then take them to the recovery unit for about 20 to 30 minutes, and if they're feeling okay, then they can go home. So outpatients, predominantly these are done as an outpatient. We do occasionally get some patients who are admitted because of pain that we happily do, obviously, very urgently. I usually counsel the patient that they should know within the next 2 weeks whether the injection is going to work or not. Sometimes it takes a bit longer, but often it works quicker. So the risks, as with any injection, really, things like infection or hemorrhage. Sometimes they may get some weakness of the limb due to the anaesthetic, which I say usually wears off in about 6 to 8 hours time. There's a risk of causing infarction, which is obviously more important the higher up the nerve root is. So infarction to the cord or even to the brain if they're doing cervical nerve roots. Often the patient may experience some increased pain for the first 24 to 48 hours after the procedure. That's often caused by the steroids kind of flaring us up a little bit. Obviously, during the pandemic, we reduced initially the amount of steroid injections that we did last year because there was a hypothetical risk that steroid could cause an impairment to your immune system for a short period. And nobody really knew what the real risks were on this, but most injections were stopped partly because to reduce patient throughput, but also we would only do them, it was only recommended to do them if a patient was in extremis or to avoid surgery. Although rates have obviously decreased a lot, it's much more safe to do these injections, and obviously people having had vaccinations is beneficial, but we do avoid doing these injections within the 2 weeks either side of the vaccination. So if a patient's had one within the last 2 weeks, we delay the injection. But if they're having the vaccine in the next couple of weeks, we ask them to either have the vaccine and come back or delay the vaccine, and we'll do the injection. The other small risk, obviously, when we're dealing with radiology is the radiation exposure, but this is very, very small for this type of procedure. And so this is what we're trying to do, is trying to put the needle tip pretty much in adjacent to the foramen of the nerve as it exits the nerve that's being compressed. And we do this, as I said, this is the images here you can see on the right side are fluoroscopic images. So we put the needle in the correct position. When I'm happy, I think I'm in the right position, then I'll inject a little bit of contrast. You may get some provocation at that time. The patient may experience some symptoms in the usual distribution, which is obviously confirmatory that you're in the right place, and that's always helpful, but doesn't always happen. Inject a little contrast to show, sometimes you can see the sheathogram, so the contrast is outlining the nerve as its course here, but main reason to give contrast is to demonstrate that the needle is in an extravascular position. Like Frankie mentioned, many patients have good relief from this. Some patients won't. If they do have good relief and it's felt appropriate to do another one of these instead of further more definitive management, we'd be happy to do that. If the patient has relief or not, obviously you can consider onward referral for further more definitive intervention if necessary. And also, as he alluded to, the problem now is that the waiting list currently in Qatar for one of these is about 12 months. So when we restarted injections, we returned all requests to referrers saying, would you please just contact the patients and see whether these are still needed or necessary to try and help our backlog. But some patients are still coming back, are still being booked from having a request 12 months ago. So I'm not sure what their outcome will be. But obviously this might be the time for us to review our own cum-TAV kind of pathway in terms of treating these patients a bit more expediently, if we can. Okay, thanks very much. Happy to take any questions.
Thank you. There's a few questions from that section, and Gavin, you touched on one in terms of the waiting lists that are currently in CTM for nerve root blocks. I'm just wondering if anybody can comment from Cardiff and Vale or AB regarding their current waiting list situation.
So it depends which pathway you're talking about. So we're very lucky to have this recently set up pathway from RIAN, which means we can get blocks roughly within a week, but they have to be screened by one of our AP physios who confirms diagnosis to ensure it's the right type of leg pain, and essentially that it's fulfilled the criteria of completing conservative management for at least 6 weeks, and the level of leg pain is severe, and we are looking for that top end leg pain to try and help these guys quickly, because they're the ones we think are most at risk psychologically in terms of mental health point of view. The traditional or sort of routine list still exists, and it was at its worst 2 years. I think it's come down from that. I wouldn't be able to give you an exact update, but it's significant.
So officially, they had said 22 months, officially. And if you look at our list, because these are only the injections lying with radiology, but each of our lists has got enough patients as well. So if you take 8 consultants, and even if they have got about 40 or 50 patients, there are quite a few patients on our waiting list as well for injections. So we've got a significant backlog at this stage. And I know we've got this service, which is great. It's good. And that's what we would want to get to and make sure that everybody gets that. But we've got to catch up on the old legacy that we have.
I think I would just add to that what I said, that if you do have patients who are in extremis, then obviously we can have that discussion and expedite any patients that need to be expedited. That's fine, and we will get to things a little quicker if need to be.
And I think Naz, Frankie, both of you agree. If you've got any ones like Gavin, you suggested, we will go to and speak to our radiologist, or we can get that done far quicker.
Yeah, absolutely. Our radiology colleagues support us immensely with those patients. And like you were saying, it is quite a lengthy waiting list at the moment, unfortunately, and it does, having worked in different health boards, I think it does vary from health board to health board.
I think the wait is also very relevant for scanning in the first instance. So it's not just the wait for the nerve root block, it's wait for the scan to confirm the diagnosis before you even request the injection. So it's both of those.
Thomas, if you want to comment on Anar and Bevan and their current pathway.
Thomas, you're breaking up. Or it's me.
No, he is breaking up.
Thomas, ask kids to stop playing on the...
Again, like Cardiff, we have two back. Can you hear me any better?
Breaking
I'm in work. If I better, can you hear me now?
Yes,
any
better.
Okay, sorry, I'm in work.
Sorry, you're gone again. Thomas, you're gone.
And two as in radiology, and both the waiting lists are quite long at the moment. I would say it's about 18 months, if not longer in radiology. But acutely, what is happening now is many patients are turning up at the Grange, and we have MSK radiologists here every day of the week, or at least 3 days out of 5. So a lot of acute injections are being done at the Grange when they are in hospital. And also MRI scans are being done quickly because at the Grange, no elective scans are being performed. So if any patient comes to the Grange, then we are getting acute scans and nerve root blocks fairly quickly. So that's been a great help. But the legacy persists, as you said.
I've got another question for the clinicians. How long do you find the nerve root block lasts for in your clinical experience?
Frankie, do you want to take that?
Yeah, so it's kind of how long's a piece of string. So some patients report that nerve root blocks haven't helped them, even though when you sort of drill down on it, it gave them a few hours relief. So all patients, in my opinion, should have some response to a nerve root block, because if you're targeting the correct nerve, because you're putting local anesthetic around the nerve that's being irritated as well as steroid. Moving on from that, it varies massively after that how long people will get a relief. But I personally don't see a huge amount of benefit in repeating a nerve root block if they've had less than sort of 3 months relief from one previously, because it's attributed to Einstein, but the definition of stupid is doing the same thing twice and expecting a different result. So hopefully that answers your question.
We've got a question for Gavin. You touched on this briefly in an answer to another question about looking at implementing the radicular pathway similar to Cardiff and Vale within CTM. And do you think that would be useful in looking at the long waiters and tackling the more urgent patients?
Yeah, I think currently, like I said, we kind of do it on an ad hoc basis, really, don't we? But I think it would be beneficial to try and formalise that a bit better and improve the management of those patients. We do quite a lot of intervention in radiology in Cwmtaf, I think, compared to other radiology departments. Certainly when the trainees come through, they get a lot of intervention experience. So I think we do quite a lot already, so it shouldn't be too difficult to accommodate separate urgent injections if we could. I think it's definitely something to think about, particularly in the pandemic. Just on the other point about how long the injections work, I usually say to patients, the medicine may work for between a few weeks to a few months, but obviously things may change inside, so you can never predict what the symptoms are going to be when they may stop working. But yeah, no, I think there may be scope for looking into a new pathway so that we can treat these a bit better.
Our last question before we move on from this session, one for our colleagues involved in interventional medicine for these patients. Should we consider neural diameter when planning for treatment? So the space around the nerve itself, would that influence whether you go for a surgical, conservative or interventional injection approach?
Do you want to take that? Nice.
Sorry, I got distracted. So
No, it's basically the size, the neural diameter, whether you would treat them injection, surgery or whatever.
No, well, it depends on the symptoms, really. Some of them can have a large disc with minimal symptoms. Some of them can have small disc with significant symptoms. So I think you have to correlate both the symptoms and the scans together. And then I think the treatment needs to be individualized.
Thank you. And thank you for that session.
Can I just quickly go back to a second injection concept that Frankie was talking about? I think, yes, it makes sense not to repeat something if it hasn't worked. But it's how the injection's done as well is very important. And we do see our trainees or anybody, even I may have done some injections and you look back and you got it. Was the needle placement correct? So it's important to look at that. And I've got plenty of patients who would turn around and say, I don't want to have an operation, I want a second injection. And they do, some of them do well. Yes, the chances and likelihood is much lower it's like a law of diminishing returns. And then, so it's you know, you got to involve the patient in that decision-making process, like what Montgomery would be, what you would do, and then let the patient decide what they would like. And some may not want to have surgery. They may say, let's try another injection. There's no harm.
Well, absolutely, Sachin. I agree with you completely that you've got to involve a shared decision-making process in that. And equally, some patients will come to see you who want surgery from the off and won't want to consider an injection, even though that might be what you want. And, you know,
but isn't it, Frankie, isn't it gone to a situation now where if I would be reluctant to operate on somebody directly without an injection? I suppose you, Naz, Thomas, all would agree that we would be very reluctant to operate, because if the injection works, why operate?
Yeah, I agree with you on Sachin. I think that would be my first, what I would do. You know, and if they have good relief, as you said, we don't change the course of the disease, but at least if we help with the natural process, that's just avoiding a surgery. And I think that would be my go-to, you know, first, and then consider if that has worked and then symptoms have returned and patients want to consider surgery, then that's fine.
Yeah.
Don't you think a really important part of that process is communicating quite clearly to the patient about prognosis and timescales, and actually this isn't we're in a movable situation. Anything is possible. It is not inevitable that you will need surgery, but for some patients symptoms don't improve. So I think the patient understanding timescales and prognosis is really key to hopefully making good decisions.
That's right. It's all about communication and patient information. You know, as long as they understand that, you know, there's a possibility without surgery, the symptoms would improve, and try to mitigate all the risks that's come with the surgery. I think a lot of them will go with your plan, and you don't have to operate on all of them. You know,
Like escalation.
Can I just say before? Sorry, Sachin. Before the pandemic, what they used to let me do here
Thomas, you're breaking up.
Is they used to let me list for both. My injections always were done before the surgery. I used to list them for both the surgery and injection, and they didn't feel that they were left behind from a surgical perspective. So if they insisted on surgery, I'll say, I'll list you for both. And many patients came back after the injection, came to pre-admission and said, well, my pain is better. I don't need the surgery. So I completely agree with you there, Sachin.
I agree, but I agree. I think you're in the same boat. They won't let you list for both now anymore, is it? Only one procedure.
Yeah.
Yes, it is coming into that at the moment.
Yeah. Right, Helen, over to you.
If we can finish off that section, but some of the questions will flow into the more general panel discussion that we have going on now to our finish just before 4 o'clock. So this is a question promptly to Joe and to Rob, thinking about the patients that we've discussed this afternoon. What physiotherapy treatments do you feel that you've tried or know about in the literature that is gratefully helpful for the patients with radiculopathy, if it's either from a disc lesion or a more degenerative structural lesion?
So it depends on timescales again. So it depends on whether we're dealing with an acute, recurrent, or persistent pain situation. And it depends on the outcome the patient's trying to achieve. So if the radiculopathy, if it has coexisting radicular pain, then that's a different outcome to achieving improvement in nerve health and function in the nerve. And that depends on the state of the nerve, whether it's overly sensitive and has a gain of function or not working properly due to loss of function. So those are all different outcomes, and that's where we need to really nail what the patients are after. If we've done that section, then I can't give you a one-size-fits-all answer in terms of the magic exercise. I'm sorry to be evasive, but you can't. But, there are a number of things you could base your reasoning on to arrive at a decision. So if your patient presents with a very mechanical picture, i.e. there are very clear patterns that provoke symptoms that would fit a mechanical compression, this sort of opening and closing patterns. If your assessment shows you that, then why not base your treatment decisions around that, certainly in the early stages of a of an acute disc prolapse, why not give that nerve more room to move, more room for blood flow around it? That would make obvious sense. But if they don't, then there's no reason to base your reasoning around that for your decision on exercise. You could base it on symptom response, and Mackenzie got a bad rep for the explanation of the mechanism of how the treatment works. But I think repeated movements still have a very key role for a lot of patients. We just change the reason why we think it's working. It's not pushing disc back in, but the pattern of that pain response is certainly still valid. You know, resolving leg pain, centralizing is still a good thing to base your treatments on. We can look at it from a physiological perspective in terms of nerve health. So we can look at some of those factors we put up earlier in terms of maximizing the positive factors around the nerve and minimizing the unhelpful factors. So, and that's quite wide ranging. It includes things like stress and sleep, as much as diabetic control and cardiovascular exercise to boost blood flow. So, or we can just look at it from a very pragmatic situation with someone with long-lasting leg pain, where really none of that matters anymore. What they're dealing with is pretty permanent. That nerve has reached its end stage state, where pretty much nothing we do now will change it. So we kind of have to deal with that as best we can and help them live their life as best quality we can with a functional approach, teaching them triggers, etc. So I kind of need to see the patient to work that out for myself, and I think you would be the same, I'm sure, as a clinician. You'd need to individualize that depending on the state the nerve's in and what the patient wants. Sorry, rambling answer.
No, I agree with all of that, and I think empowering the patient with advice and reassurance on symptom response and anticipated reaction to strategies, so they can problem solve and work out the things that are good for them individually. So education and empowerment of the patient to work out what's a good response, what's not such a good response, and things that they can explore to achieve, you know, recovery of function, centralization, improved sleep, etc., so they work it out for themselves.
Thank you. If we can pass over, I don't know if Thomas's Wi-Fi is up to that, but Sashin, if you can jump in and help out on this one. A question from session 1 regarding the signs and symptoms suggestive of myeloma.
I suppose sorry, I'm not sorry, I don't want to sound patronizing. I suppose it's myeloma or myelopathy. Myeloma, the symptoms would be somebody who's got, like, would be any red flag, unremitting pain, nocturnal pain, thoracic back pain, all those sort of things. Myeloma is more of a radiological or a diagnosis based on blood investigations, urine examination, bone marrow aspirate. So I think that will be more like a red flag presentation for those patients. Like if we're talking about myelopathy, that's a different remit altogether.
Do you want to continue on myelopathy?
Yeah, so myelopathy, as I think Naz mentioned earlier, and I think Joe covered as well, you know, gait disturbance would be an important one, like losing balance. They may find that patients may find it difficult to do fine motor function, like, you know, buttoning their shirt up. The other thing they find when they wake up in the middle of the night, they got to go to the loo. They have no idea where they are. They're completely disoriented. You know, when they're walking, they feel they're walking on cotton wool. They can't feel the ground properly. Their legs give way. They feel they have to keep looking at the ground to walk because they're using visual proprioception rather than a normal proprioception. When we walk, we don't keep looking at the ground all the time. I can walk. If I have to scratch my nose, even if it is pitch dark, I can scratch my nose. I know where my nose is. I don't need to look at it, that my nose is there to scratch it. So all these sort of things will help you understand what's going on with myelopathy. And then, of course, on your assessment, you'll pick up upper motor signs. Like, you know, the planters would be upgoing, the reflexes would be brisk, all those sort of things that you will pick up as well.
Thank you. And a question as well from, again, this earlier session from Naz, and if any other the spinal surgeons want to join in on the wider picture with this. It's a question about the spinal fracture patient that you mentioned in your earlier conversation. How did it end up being managed? And again, how do we manage these patients from primary care through to the secondary and tertiary care settings?
I think in this instance, she was already in the hospital. I think she was assessed in the A&E by the physiotherapist, trying to see if they can go home, but they failed their, they were unable to go home. So from that point of view, they got admitted. We had to involve the acute pain team to try to control her pain. We gave her a brace, mainly not for stability, but more for pain relief. So when she was in bed, she didn't wear the brace, but when she was mobilizing, she did wear the brace. What's important is that patients who come with vertebral fractures due to osteoporosis, you got to treat the osteoporosis. If you have vertebral fractures, you have a 4 to 5-fold high risk of sustaining another vertebral fracture and a 3-fold high risk of sustaining a hip fracture. So I think treating the osteoporosis is important. So we gave her a infusion of zoledronic acid, which will cover them for at least 12 months. And then, which is also important, is that some of the, I think there's a previous question about myeloma. Some of the myeloma patients can present with fractures. So whilst they're in the hospital, we also investigate to rule out myeloma.
Thank you. Does any other of your colleagues want to add anything in terms of management of spinal fractures?
On spinal fractures, there's growing evidence that we should probably be a lot more aggressive with our interventional radiology colleagues around these. So the previous argument has been that the studies have shown no significant improvement between kyphoplasty and vertebroplasty, and a lot of the evidence coming out from the US, in particular by a radiologist by the name of Doug Beal, is now showing that actually the numbers needed to treat to save a life with vertebroplasty is only 15 patients at 5 years. Sorry, 15 patients at 2 years and 10 patients at 5 years. And he's also shown that in his study group that actually its restoration of the vertebral height is very positive in prognosticating whether they will survive for those 5 years or not, whereas those patients who didn't have restoration of the vertebral height, they didn't survive. So I think this is probably going to be a massive problem for a lot of us throughout our career, because these are not fractures that will do well with conservative treatment, and quite often these ones will go on to present with significant deformity as a result of sort of neglected fractures. And whilst those ones may be few and far between that we then go on to operate on, it's probably worthwhile thinking about changing our way of treating these at this stage. But as Naz was alluding to, prevention is far better than a cure for these patients.
Thank you.
Helen, there's a question in the tab about the myeloma thing. I think, thanks for getting back. I think, yes, you're right about bloods. That would be a red flag, and that would be going into an acute spinal clinic or via A&E, whichever way the patient presents, because they could present as a pathological fracture as well, for all you know.
To be honest, Sashin, if somebody presented in FCP though, and they were systemically unwell, losing weight with fairly significant back pain, then my advice would be we need to get routine bloods from primary care and get the GP to review them. And if they need, referral into TNO and MRI, that's the pathway for them. So really those patients, we would hand over to the care of the GP to say, this isn't mechanical, there's something else more sinister that needs further investigation. And the GPs are more than happy then. They know the pathways and what needs to happen.
Okay, there's a question in the question and answer session again, and the question is, if there is an acute neurological deficit but non-progressive, should it be the absolute indication for surgery?
I think Thomas's mic is working better. Thomas, can you hear us? He said he's moved to a better Wi-Fi zone.
Can you hear me?
Yeah, we can.
Yes.
Right. I was just looking at that question answer. I couldn't find that question. Can you repeat that question? Sorry.
So if there is an acute neurological deficit but non-progressive, should it be the absolute indication for surgery?
Right. I think that depends on two factors. If there is a deficit, how long has the person had the deficit? And two, is it associated with pain? So if you're talking about radicular pain with a deficit, that is more of an indication for surgery. Obviously, again, like we discussed before, I would discuss this with the patient. But if the deficit has been a long-term problem, or it has been a long time since the deficit, and also if it is a painless deficit, I think the chances of improvement are much, much lower. So I would, again, discuss it with the patient. Now, coming from a primary care referral perspective, I would say if it is an acute foot drop, what we talk about is this needs an urgent referral to be seen. And I normally recommend within the next few days, we recommend they come to one of our spinal fracture clinics so that we can see the patient there and then make a decision. Does that answer the question?
Yes. Does any of the spinal colleagues want to add anything in addition?
Frankie?
No, I agree with Thomas. I think any acute neurological deficit warrants urgent referral into the spinal service, whether that's an Iron Bevan or Cardiff and Vale. Whether it's an absolute indication for surgery depends on the cause of that acute neurological deficit. And like Thomas was saying, the presence or absence of pain, age of the patient, length of the, how acute is acute, and lots of different factors. Certainly a reason to consider surgery, but there's, I think we're fortunate quite often in spinal surgery, there's very few situations where there's an absolute indication for surgery.
Do you think it matters as well whether the symptoms are changing? Because it's not unusual. We do come across them in primary care with a 2-3 week history of a weakness. You follow them up a week or fortnight later, things are improving. So if something wasn't improving by 6 weeks or was actually worsening, then I would arrange for them to be reviewed much sooner.
So, I'd say it all depends on the grade of weakness. If we're talking 0 out of 5, I think we need to see, or well, even less than sort of 2 out of 5 or 3 out of 5, is that sort of grey area where you're not going to necessarily rush in, but it should be kept under review to see if it's progressing or getting worse. But below a 3 out of 5, I think I personally would be keen to see it, to be in that sort of shared decision-making process. A 4 out of 5, I wouldn't necessarily class as a neurological weakness.
But I think, Joe, your point is correct. With progressive weakness, you've got to get on, do the procedure. We do see quite a lot of patients who improve, but any neurological weakness, I think, should be flagged up. In the pathway, you can see, with the pathway you showed, the red flags are there, the middle bit, which is acute, and then the chronic.
And there's a follow-up question to that, Sachin, from one of our colleagues in FCP. If you have an acute myotomal weakness, not foot drop and pain, should we still be watching and waiting for 6 weeks or scan urgently?
Naz, do you want to take that?
Again, it depends upon the grade of weakness. As Mr. Brooks mentioned earlier, 4 out of 5, it could be pain related. You wouldn't necessarily jump into doing anything. I think I would, for that grade, I would wait. But anything less than 3, then yes, I would act quicker than wait for 6 weeks.
But can we make it a little bit more simplistic for an FCP who's actually on the front line seeing a patient and they identify a weakness? Yeah. Would it not be fair to say that patient could be referred across? And if you look at it, Frankie looks at it, Thomas looks at it, and they say they've got radicular pain, they've got weakness, then usually we would fast track them generally, isn't it? Okay, we may not see them next day, but we would see them fairly quickly, isn't it? Would you agree? I think all of us have said something similar on that.
Yeah, I'd agree with you, Sash, and I think a problem shared is a problem solved almost. You know, if there's a weakness, I do not know anyone who will be opposed to seeing that and assessing it. In terms of, I think it was Jessica was asking about the if it's a non-foot drop. I think that they're almost, if we're talking about a quadriceps weakness, that can be so much more devastating than a foot drop that can rob a person of their ability to stand. So yeah, we need to see those ones. You know, foot drop, any neurological weakness, we need to be seeing if there's an ongoing concern, or at least having that discussion.
Another important point I would like to highlight is, you know, when a referral comes through, and I think all of us would agree on this, that if it is clearly stated what dermatomal pattern there is for the pain, then from my point of view, even if there's, like I'm talking about now without weakness, so rather than making that patient wait to be seen in clinic and then sent for the injection, I would fast track them. I would put them straight away on the list for injection. What that does is it takes away that routine wait to be seen in clinic or whatever wait we put them in. So it takes one, you know, it reduces the patient journey. And I think we would all agree, if you've got the right information, obviously we've got the imaging to look at. So you look at the referral, look at the imaging, and bang, you got an answer. I think I would just do that. And I hope others, nice, Frankie, would you agree with that, Manoj?
Yes, I think that's where the importance of CMAT clinic and the combined physiotherapy, radiology, and the consultant virtual clinic does help. You know, you try to minimize the long waiters. You try to prevent them going into a chronic pain condition. You want to try to intervene early. You know, you see them, you know, even you don't have to wait for 6 weeks. If the pain is excruciating, at least do an nerve root block. That will get rid of the pain, hoping for the natural process to then go on. And if the symptoms do come back or don't get better, then there's always a chance of injecting again or doing different types of modality of treatment. I think the intervention should be sooner in terms of the pain management.
I think the clear take-home from message for us as physios is if we are communicating with you, we state very clearly the corresponding dermatome. So that you've got a level and describing, you know, it's C6 or L5 or whatever, so that you know in the referral what you're looking at on the scan.
Yeah,
sorry.
I just echo that. I think
Thomas, go on.
It's not always clear though. So when it's not clear, we should say it's not clear on the referral.
No, but even if you say that this is where the distribution is, if you don't put a myotome or dermatome down, I suppose Gavin would like that as well. Our radiologist would like that as well. If you tell them the pain is in so and so area, okay, that report looks quite lengthy, but then they will concentrate, this is where the patient's pain is coming from.
Yeah, definitely. No, it can really help us correlate what we're looking at with what you're telling us. And if we can say to you, look, it's because of this, then obviously that's much more satisfying for us to do that, and for you and the patient, obviously.
So if you ask the right question, you'll get the right answer in a way, isn't it?
And the grade of weakness, and the grade of weakness is good if they could put it on. If you're saying foot drop, you know, are you talking about grade 0 weakness, grade 2? That helps us also make a decision how quickly the patient needs to be seen.
If I can expand on that question, and it's something that can cause some delays in patient care in terms of the correct information on referral letters in order to assign a level of urgency to it. You talked about patterns of pain, neurological loss. Is there any other information that you would feel that you would want on a referral letter to be included to aid that triage process and allocation of need?
Frankie, do you take that?
Yeah, I'm happy to take that. So I think the thing that always does annoy me to a degree is when urinary incontinence is put on a referral letter, because that, in my opinion, if there is any concern that patient has cauda equina syndrome, as was covered earlier, that patient needs to be referred in urgently to the hospital and not via a letter. So I'd say I don't want to see urinary incontinence on the referral letter. I think size, site, distribution, grade of weakness, and how much of a conversation that you've had with the patient is always helpful. I have had from the oncologists before a patient referred, where they mentioned the life expectancy in the letter, but didn't tell me that they hadn't told the patient about his life expectancy, which led to an awkward conversation. So that, you know, I think as much information as possible without it being sort of war and peace.
I would add one more, that is duration, to what was put in. Just with regard to pain, as well as if there is a new weakness as well. So duration of symptom is quite important.
At this point, I would like to ask a question. Helen, could you put a poll up, yes or no, on the question? Very simple question. Is there an appetite in the region, right? I say region because we take patients from Kumtaf, and we've got to look at that as well because we're responsible for Kumtaf as well. Is there an appetite? Because I know, Joe, you may remember, we put a referral form together. Should we be putting something like that together so that then it ticks the boxes? I know it becomes very prescriptive. Then we're all, you know, looking at those boxes. Do we do that, or we just put, as long as we've got that basic information that comes through? I don't know. It's a point to discuss and see what everybody feels.
Sachin, do you think it's also helpful in the referral letters to have whether or not the patient's prepared to undergo surgery or not?
Correct.
Yes, I was about to mention that. I think
Sorry.
it's important that you have the discussion and the patient wants to explore more options. You know, there's no point if patient doesn't want to have an intervention, then it's just a waste of you know, a slot. We could have seen another patient who would have been more willing to have surgery.
Okay.
Just a follow-up question for that is, do you want to have an MRI scan performed before the referral, or wait for the MRI scan results before referral is initiated for a non-urgent case?
For a non-urgent case, I'd always prefer to have the MRI scan beforehand, but obviously if it's urgent, I'd prefer to see the patient and get the MRI scan.
Thomas, what do you think?
That's very interesting because the radiology department in AB has about 18 months ago gone for nice guidelines to say that any MRI request should include a referral to the spinal surgeons or spinal physios. So we suddenly having increased our referral rate from primary care to nearly 50 to 70% up post-pandemic, just because of the change, and they're not able to get direct MRI requests. It's also made it more difficult for us to triage patients because we don't have MRI scans anymore, and we're going mainly based on the letter. And I think this brings your point, Sachin, of how much information could we ask for. In our internal referrals, we give them a form. You need to fill this form, which has all the details in it. But we haven't put that to primary care. I think it's probably a bit more difficult in primary care, where they have 10 minutes to see a patient and, you know, to fill up the detailed neurology form for their referrals. But yes, it would be useful to have an MRI scan before referral for non-urgent referrals, as Frankie has rightly pointed out.
Just expanding that in Kumtaf. So in Kumtaf, we follow a similar pattern, really. We have still got technically open access to primary care, and we're happy to accept requests for whole spine imaging. There's potentially sinister causes such as METs. But we also, a few years ago, kind of instigated that non-specific back pain with or without sciatica doesn't need imaging in a specialist setting. And so we really do encourage the referral of those patients from GPs to our MSK services, whether that be the triage or health board physio, mainly because the GP will request a scan, then that patient will wait for that scan. The GP will then get the report and then refer it to someone else, and then they'll wait again. And I think if we can change the flow to be seen by somebody who can also treat them very quickly, and get the scan if needed, and then deal with the onward referral in one go. I think that's why it's much better for us to try and encourage the flow of patients via the MSK services before they have imaging, in my opinion anyway. And also because now we know, well, always we've had demand for imaging has outweighed capacity, which makes it even more important, particularly currently.
I can add
We've
a
got
bit
a
to that.
similar issue because our GPs can't get MRIs. There's a little bit of an embargo on them, but I agree, if they've got certain things like radicular pain, red flags, I think that will go through. And if it is non-radicular, pure back pain, they'll have to go through CMATs for us, which I think makes sense.
Or FCP. So I think FCPs working in primary care have access to imaging as well. But generally, we will have explored the conservative management, and they've had a clinical assessment before that, imaging takes place.
See, the other one, which is a little bit of a, I don't know, it's a little bit of bugbear for me, is X-rays. Unfortunately, GPs can't do anything, so they'll get an X-ray done. And that X-ray is of no help most of the times. Like 99% of the times, it's of no help. And, patients roam around with that report saying, oh, I've got this, I've got that. And you go, so what? That's not what is causing your problem.
I think in the new pathway, though, primary care can't access plain films unless there's a history of trauma.
That's what NICE guidelines say.
Well, that is what should happen now.
Yeah, so in Cwmtâr, so they can only request plain film of a lumbar spine if it's query osteoporotic fracture or other fracture. So yeah, no, we don't just accept them anymore. But it does leave very disgruntled GPs when they can't request any imaging at all. You know what I mean? So it's managing them and educating them as well into using the services. And in the last 4 months, because we're still getting paper requests, we've started a process of, if I get a request on my desk which I think needs physio, not a scan, I'll scan it and email it to the physio department, and then they deal with it straight away. So that's been working pretty well so far. So we'll see how that goes. But I think it's best. I think it's the best pathway to follow. Really.
Can I jump in that, because we absolutely feel that we feel the frustration of GPs who feel denied imaging access, and I think it's been really interesting working in the acute clinic where we're seeing patients come in who have been assessed from FCP clinicians very thoroughly, very accurately, but usually over a phone. And it's extremely difficult to differentiate high levels of distress from high levels of radicular pain. And we've had several patients that come in, and I've done this myself, where you speak on the phone and you're convinced this is truly awful, and it sounds really horrific, and you see them that come in and they're clearly functioning at a very high level, and it's clearly not radicular pain, and it's extremely hard to pick that over the phone. So that's one of the benefits we see, is that when we can get these guys in and actually have a proper thorough assessment relatively quickly, that triage to imaging or not suddenly becomes a lot more accurate.
Can I ask a question? I know this is not completely relevant to this, but it's slightly relevant from our perspective, being very selfish. X-rays that we do across the region, can we, Manoj, you can help us, and Gavin, and we'll have to change a little bit on our end. So we do all our X-rays standing. We don't do any X-rays laying down anymore. Like knee X-rays, they're all standing lumbar spine X-rays. Is that what we can try? Because now we look at imaging from everywhere. We don't need to get those X-rays done again, repeat X-rays locally. Is that a possibility, Gavin and Manoj?
Yeah, certainly it's a possibility. We do get requests for weight-bearing X-rays for spines usually it's come from spinal services, really. And we're happy to entertain those. Our radiologists get a little bit nervous if they're acute patients who've had trauma.
Oh, no, I'm not talking about trauma. I'm talking about patients from elective clinic with back pain. So just standing X-ray for everybody. And on that note, we could also flip it. And rather than going AP, we go PA, which reduces radiation, which is something we are trying to implement, hopefully, in the near future for us, which will be good. This is a separate discussion, which we need to have outside.
Yeah, no, I think that'd be, easily accommodated. Yeah.
Helen, any more questions?
We've just got some questions, and it's again about spinal fracture management, about the indications for vertebroplasty in terms of mechanism of injury and age limit of a patient.
We'll ask our expert, Mr. Brooks, to answer
that. So mechanism of injury doesn't impact on whether you can or cannot do a vertebroplasty, and I'd say in the sense that I do not want to be ageist. There is no age limit, but obviously it's about physiological demand to be able to withstand the procedure. Hopefully that answers the question.
Thank you very much. And there was just one last question. Again, it's for Rob and Joe, and that will finish the question and answer session. It's, would you consider any high impact exercise for improving disc nutrition? Is there any evidence in the literature regarding this?
Go on, Joe, you go for it.
Well, I've just said that I just know of one paper last year which has looked at moderate distance running, and it actually found that it did increase disc height.
Yeah, so I think there's been a lot of scaremongering around impact loading and flexion on the whole, and I think we're moving on from that, hopefully, that there are patients who are sensitive to those things and they need to be adjusted for pain control. But in terms of actual tissue damage and tissue pathology, I think timescales are super important here. If someone has just literally had a disc injury, there is a period of time that needs to heal, and it's perhaps a bit longer than you would give a standard muscle tear. But equally, if someone is loading regularly, the discs will respond just like a muscle. So we've good evidence now that loading discs is good for them, and that includes discs that are dehydrated on imaging, because that's essentially normal. There is a slightly higher incidence in those discs that are desiccated or darker, having a chance probability of having back pain, but not leg pain. So if you look at weightlifting studies, the weightlifters have got tougher, bigger discs because they're loading on a very regular basis over a long period of time. We shouldn't therefore translate that into someone who had a disc injury last week, and then put them in a gym and deadlift them. I think you need to put an element of common sense around that, but certainly the evidence is a lot more reassuring than it used to be.
So is that the holy grail? That's why Forrest Gump was running, was he? For years and years and years. Oh, I remember that now. I'll start running now.
Graded loading fixes the world.
Yeah, anecdotally, I remember a patient who had a resolving radiculopathy, resolving leg pain, some residual calf pain, and I'd done all sorts of stuff with him in physio. Last bit of symptoms, really quite low level, and it's probably 12 months down the line. And he just thought, I want to go back running. I said, just go for it. He went back running, and that got rid of the calf pain. So that was the thing that allowed him to recover full function and fitness.
Yep, several patients similar, just permission to run sometimes.
But don't we tell them normally, isn't it, that if it doesn't cause pain, go for it? Like, absolutely. That's what I tell them. I never stop them from anything. If they say, I can do this, I say, go for it.
Even if it does cause a bit of pain, if they really want to do it, that's fine.
Yeah.
It's only neurological loss that I'd be more concerned by, or excessive symptoms that they're giving pain for a week afterwards. That's just clearly common sense would say you need to be a bit more comfortable. But yeah, there's no reason to pathologize around that. I think we can be a little bit more encouraging now.
Okay, Helen.
Thank you. That's all the questions answered. I would like to finish the session by thanking our panelists today, who are all very busy clinicians working within spinal units and physiotherapy departments and our radiology departments. They feel passionately about improving spinal care within the 3 health boards, and I'd like to thank them on your behalf of giving up their time today. As we mentioned earlier, myself and Sasha and Joe and Rob have had some thoughts about developing a Southeast spinal network to involve clinicians from a multi-professional aspect to improve patient care pathways, so that irrespective of where a patient arrives at the front door, the treatment is harmonized, it's evidence informed, and it's the best quality patient pathway that we can provide across the 3 health boards. So we're hopeful that if you've enjoyed today's webinar, this will be the start of the conversation in terms of developing this network further and providing some further educational sessions and some group working towards harmonizing our patient care pathways. For those who were unable to make it, the webinar has been recorded and will be available on the MACP website. And I'd like to thank Rob as regional rep for the MACP and the MACP for allowing us to host this talk and use their webinar facilities today. Thank you again for everybody attending, and we'd like to wish you all a pleasant evening.
Thank you.
Thank you. Thank you, Helen.
Thanks very much.
Thanks.